Good morning, everyone. Welcome to the IEHP pre-conference event. And today we're going to be looking at systems approaches to removing barriers for IEHPs to integrate into practice. My name is Dwight Baker, and I am the mentorship coordinator at PEGASUS Institute. Just to note that the International Health Professionals Program, or you'd sometimes hear us use the acronym IEHP, is a program by PEGASUS Institute in partnership with the Canadian Medical Foundation. And in the true spirit of partnership, I am pleased to have the Immigrant Services Association of Nova Scotia, ISANS, hosting us today for this event. Now, we're so pleased to have you join us. So to those in the virtual space and also, of course, our in-person attendees, welcome to this session. Now, this event brings together key decision makers from 6 different organizations, regulatory or professional bodies, government representatives as well, and internationally educated healthcare professionals, of course, persons who we are holding this session for. The aim here is to, of course, explore those collaborative solutions to improve licensure process and workforce integration pathways for internationally educated healthcare professionals in Canada. Before we begin, I usually like to take a bit of time to go through the land acknowledgement, and today it's no different. So I'd like to acknowledge that we are gathered today in the Maki, the traditional and unceded territory of the Maki people, okay? This territory is covered by the treaties of peace and friendship, which the Mi'kmaq and Walastoqiyik, and I'm hoping I'm not mispronouncing those, please forgive me there, or the Maliseet peoples first signed with the British Crown in 1725. So as we gather, we honor the enduring relationship between the Indigenous people and this land. We work to improve access and equity for internationally educated healthcare professionals. And as we go through this process, of course, we're reminded of our collective responsibilities towards reconciliation, inclusion, and respect for all communities that sojourn here. Now, I want to begin by acknowledging that many of us are gathered here today. We have our personal journeys that we have gone through. So those journeys may have taken us across continents, countries, oceans, to come to Canada, to call Canada our home. And there are those, of course, who are in this session who are looking in. Okay, so they're outside already looking in to join us here in Canada. Now, some of you that are already here, you may have came here by choice. Some of you may have been forcefully displaced, coming into Canada as refugees. Carry your dreams, your expertise, your own professional identities, whatever those be. So these are built through years of dedication as a professional within your home country, and now paused or placed on uncertain ground. Now, as an international pharmacy graduate myself, hailing from the island country, Jamaica, all right, I'd like to let you know that I also experienced some of those barriers. And while I'm not here to talk about my barriers today, I'd like to say I do acknowledge some of the struggles persons go through as internationally educated healthcare professionals coming into Canada. Struggle to find reliable resources to guide you through the process. That is a real challenge. To bear the financial burden as well that is associated with the licensure process. So exams that you have to take, the courses that you have to do, bridging courses, sometimes bridging courses that are also supposed to foster integration, but does not have that real integration component associated with them. And then there's an invisible wall that some persons might hit, especially for international medical graduates. The recency of practice requirement that comes with that. So you have all these criteria that you must fulfill. And then by the time you complete some of these criteria and reach to that point where you are supposed to become licensed, then you're hit with recency of practice and you realize that you cannot meet that at any point in time. Okay, it becomes even harder for our refugee IEHPs, and I will continue to speak about that because when we look at the persons who face some of the most disadvantages in terms of integrating, you'll find that our refugee IEHPs are at the most disadvantage where that is concerned. All right, so while for those persons who came off free will, sometimes they may be able to go back to get that recency of practice. It is not so easy for refugee IEHP to get that recency of practice. The path can feel like a tunnel for some persons, with the light in the distance seeming attainable. And then by the time you reach to that end, all of a sudden, you're put onto an alternative path, okay? Something that may not have been intended, but that is the system, and that is what we are seeking to change today. So now, this session, of course, will go through some of those barriers. And we have a lot of brilliant minds. So joining us virtually, joining us in person, we want to explore some of those solutions, look at how we can overcome or navigate those barriers that we are faced with. Now, the IEHP program at PEGASUS was created with this vision, and it continues to grow, all right? So last year in April, we launched our mentorship program, and we continue to serve IEHPs through our mentorship program, connecting persons to resources, connecting persons to other professionals that are practicing or already integrated in Canada, as well as connecting individuals with their peers as well to offer some support. The path can be long and dreary, but it doesn't has to be alone. And so for all of you that are with us here today, and for all our IEHPs who are joining us virtually, you do not need to walk this path alone. And so as you listen to our speakers and panelists today, I leave you with two critical questions. How can we remove some of these unnecessary hurdles? That's the first one for healthcare professionals so that they can integrate into practice seamlessly in Canada. And then the second one, what responsibilities do we each hold? All right, as regulators, as educators, as community service providers or integration partners, what are those responsibilities to progress or advance those discussions, to make those changes happen so that persons coming into the sector can apply those expertise that they have, all of those experiences that they have garnered over the years, practicing in medicine, practicing in pharmacy, in dentistry, midwifery, nursing, the various professions, okay, so that they can contribute to the development of healthcare as a whole here in Canada. Now, I've spoken for quite a bit of time, and at this time, I'm not the keynote speaker. I'm just going to introduce the keynote speaker to you at this time, Dr. Sepideh Behroozan. And now I'd like to say Sepideh has quite a track record as well. And one of the most poised person here to be the keynote speaker for this event. Now, she's a family physician at the Newcomer Health Clinic here, which is, of course, close to where we're having this session now. So if you walk across the hall, then you're right into her practice space. Now she has a well-decorated career as a pediatrician coming from Iran, and she's an international medical graduate, so let me say that. But you know what's unique about Sepideh's journey? She's also a medical graduate of Canada. And I think she can tell you about that program, of course, how she gained those two titles. She did not redo medicine, okay? But she's a medical graduate of Iran and of Canada. Now, she has quite a bit of experience working with refugee-IEHPs, also supporting other refugee-IEHPs and IEHPs as a whole coming into Canada, providing guidance and support to those individuals, and herself as well. She has quite a bit of lived experience. So yesterday I was told, just name the program here. Sepideh has gone through that program. Okay, so as a program participant, and she's also here to share that knowledge with you. Please, without further ado, help me welcome our keynote speaker, Sepideh Behroozan, as she comes to address you.
I don't want it to be about me or what I did, because over the past few years, I have learned that many people are heroes, that I look up to them, and no one knows about them, how they struggle, either became successful or not. So I have prepared a few things through facts to say, and then later, if you are interested, I'm happy to say how I became IMG and CMG and all of those. So first, the warm-up. Raise your hand if you are not born in Canada, please. And online, please send something, some notes, something. I believe you can say like.
You can use the raise hand feature as well.
Okay, raise hand, please. Thanks for that. So I believe I don't see the numbers, Dwight, online, but I can see in the room.
Okay, so we have 88 persons online.
Okay, perfect.
There are quite a bit of hands going up as well.
Okay. Now, if you speak more than one language, please raise your hand. And online. And I don't know the numbers there. If you speak more than 2 languages, please raise your hand. Thanks. And thanks. So in less than 1 minute, we realize that we are global, we are multilingual, and we have diversity in Canada. So we are not looking to diversity in future. We are diverse now. And we want to know why healthcare system does not recognize that or address that. That we really have a pool of talented, I believe, people who are ready to offer their skills to Canada. Don't get me wrong, I'm against the fact that newcomers come in and start working. IHPs come in and, okay, you can go in this hospital and work, because it's a huge change, and definitely people need to learn about the system, be really not checked, but assessed, getting the chance to learn about this new system. But even if they do that, the rate of success is very low. Now, it's interesting. For this talk, I realized that 260,000 IEHPs are now living in Canada. This was based on 2 years ago stats, and I'm sure now it's worse, because in some of the countries like mine, I'm from Iran, now there's a huge flood of IEHPs coming out. So it's important to know that many of these people, especially the ones who are coming as refugees, they have delivered babies under candlelight in refugee camps. They have triaged blast injuries. They have run vaccination drives in remote villages, and they arrive with clinical mastery, multilingual comfort, and resilience, which many of us can only imagine. So these are not trainees. These are change makers, and they are on standby. There's a disconnect, because if we now know that we have 260,000 IEHPs in this country, it's really heartbreaking to know that only 58% of them will work in healthcare system, in healthcare sector. And among those, there's a 41% of IMGs, 42% of nurses. If they are hired, they are working in the job that they were trained for. And meanwhile, we have 6.5 million Canadians without a primary care provider, either family physician or nurse practitioner, or any kind of primary provider. 6.5 million is a city, a large city. And I work only with refugees. So I work as a family doc in Newcomer Health Clinic. We provide services to refugees. I see people who come from really areas that no one can imagine surviving there. They are telling me that, is this what we see in Canada? No doctor? What are you talking about? 1 year waiting to see the specialist, or 2 years to have an ultrasound? What are you talking about? So we are importing the talent here. We are exporting the hope. And in the middle, patients are waiting. Now, I thought a lot about what are the barriers, because the barriers, there are lots of barriers, but we can blame more easily the systemic barriers. And the first thing that I realized when I arrived was that I was lost. I had ISANS, luckily, but I was told apply to, at that time, PCRC. And I was saying, what is applying now? I went to the website and they said, print this cover letter with each of the documents. Just realizing what is the cover letter, how to have it there, not to staple it, and how to send it. It's really, really something that needs help and support, which in Nova Scotia we are lucky to have. And I'm sure in many provinces you have fantastic services. But the problem is that the licensure rule shifts from one province to the other province. So it's like having incompatible phone charger, or the power that you go from here to Europe. It doesn't work. And in all the provinces in Canada, unfortunately, we have that problem. Immigration policies wave people in, then the regulatory bodies keep them back, send them to the end of the queue. So the immigration says, yes, come in. Regulatory bodies says, no, sorry, not yet. And I did not realize this when I came in. So I was thinking that, okay, I passed the exams. At that time, EE, Q1, Q2, all the exams. I have the licensure of Canada. What can I do now? Nothing. Because I didn't know that this licensure is a paper. Working is something different, regulatory body, and that's based on the provincial, on a provincial level. So it's very confusing for any of us who comes here and wants to really solve this mystery of how to apply. But I don't want you to be all disappointed or hopeless, because there are also good news. There are models of success, but unfortunately in silo. I have always been in Nova Scotia since 2008, so I have no clue about other provinces. But I know that in Nova Scotia, ISANS, which is our main settlement services, pairs newcomers with mentors. They decode paperwork. They offer cultural navigation. And basically, they become our family, mentor, teacher, everything. There are practice-ready programs in Nova Scotia, and I'm sure in other provinces. And they are working to fast-track the physicians to rural communities. And they are desperate in desperate need for them. There are grassroots peer mentor circles, often run on coffee and goodwill, and they have helped hundreds of IEHPs. And I believe knowing Neil for PEGASUS, he is one of those people who, as a role model, has done that. So the programs work, but the problem is that these programs are not universal. It's silo, one here, one in other, one there, and they are all not aware of the other one's existence. So now, I don't want to be negative. So what can we do? I believe we can have a few things. One, if in a dream world, we can have harmonized credential recognition, a single, transparent national standard that applies to everyone. So if we come to Canada, we go to somewhere, it says everywhere in Canada. Even realizing where is Saskatchewan, where is Halifax is difficult. not for us. If I go to Toronto and I'm in a taxi, they ask me, where are you from? And I will say, I'm coming from Halifax. Halifax, there it is. And they are Canadian. Many people do not know what exists east of Montreal, unfortunately. And for the ones who are online, Halifax is very beautiful. So please don't. I'm biased about Halifax. So the second thing that I can think about is investing in integration pathways. The way that they invest in hospital beds, we invest in starting this clinic, we invest in funding hospital bed for this area. So I believe it's great if we can fund bridging seats, supervision stipends, language coaching, mentorship networks. So those are the things that would help. The other thing, third one, is that we have mountain of data. I believe there are so many projects and research done on IEHPs. We have lots of data, and we are continuing on doing the research. But maybe it's good to start implementing those and to move from pilot projects to pilot policies. And the last one, the most important one, I believe, is having IEHPs at the table when they are making decisions, and not just having them on the waiting bench to tell them what's going on and what we decided for you. That's the way that here health care is provided, patient-centered care. So when we say patient-centered care, means patient is not sitting at the corner of the room and we decide this is better for you, this is your prescription, buy. We say, what's your opinion? What do you think? What do you want? So probably that approach would be helpful if the people who are going to be affected are also decision makers. Last night we had a session here, and I mentioned in Nova Scotia we had a fantastic multi-stakeholder group for years. All the decision makers were sitting around the table, from college, university, Doctors Nova Scotia, IRCC, MCC, all the representatives plus IRMHC. And that multi-stakeholder group really was successful. And for the 10 years that I was attending it, because I was taking time off from school residency to attend that one, we made lots of changes. But unfortunately, the fund was gone and it stopped with no notice. So I just want to remind that IEHPs are not waiting to be trained. They are waiting to be trusted. And it's not about charity. It's about smart, inclusive policy for a healthier Canada. So I prefer not to call them foreign trained. Maybe it's better to say future ready. And at the end, another show of hands online, please, too. Who is ready to turn today's discussion into tomorrow action, doing something? Thank you so much. I'm online. Thank you.
Hey, thank you, Dr. Behroozan, for such wonderful opening remarks. Okay, and call to action there. All right, so like Dr. Behroozan said, we're already trained. We have all of these vast experiences. It's not a charity. We're ready to work, okay? And I did see all of those hands going up online for all of those persons who are ready to start the process. All right, so let's see how we move from here into action and going towards, of course, that implementation phase. Now, to continue the conversation, I have with us, and I see him smiling over there, Dr. Filipe Santos from the Medical Council of Canada. Dr. Filipe Santos is an international medical graduate, special advisor at the MCC, and the Royal College of Physician and Surgeon, certified anesthesiologist, and assistant professor at the University of Toronto. Now, Dr. Santos joined the MCC in March of this year as an MG special advisor and will be supporting the organization's strategic objective of actively assisting IMGs as they navigate the practicing landscape as physicians or future physicians, right? Let's take this keynote speaker's term. So future physicians to moving to other medical roles here in Canada, including through preparatory tools. Now, as RCDSO certified anesthesiologist and assistant professor at UFT, Dr. Santos received his medical education in Brazil, where he also completed medical school and his residency training, and later earned a PhD in pharmacology. All right. Informed by his own experience as an IMG, he has supported and mentored many others, hoping to practice medicine in Canada. He also has a very active social media presence, so high LinkedIn follower, LinkedIn count there, I was told. So for those persons who are listening, someone to connect with there, don't just send, that connect request without the note. I like to see sometimes the note to tell us why you're connecting. Please help me welcome Dr. Filipe Santos as he speak to you today in this conference.
Hi, everyone. I really love to hear IMGs or internationally trained physicians speak because I relate in so many levels. And I think a lot of the people that are trained in Canada, that were born, raised, and trained in Canada, do not realize a lot of the barriers that we face coming in from another country. And it's hard. I don't blame them for not realizing because it's not their lived experience. But it is also, that is one of the reasons why I believe it has been so hard to start change, because you can't change what you don't understand, what you don't see, right? So one of the things that I think has helped is that, for example, I'm here representing the Medical Council of Canada as an internationally trained physician, and because I am an internationally trained physician, and that is a change in itself, because now we are in a position where we can share a perspective in a place where this maybe might not have been shared before. And there has been so many aha moments in the MCC where for me was something so clear, crystal clear things that I think needed to be, that I didn't even sometimes think that they were noticing. And that also changed my perspective as an international trained physician, where we don't have to, we don't need to feel like we have the burden to educate people about our barriers, but at the same time, it's really hard for us to get buy-in and to also get make changes if we don't help people understand what we feel, what we're facing, what are the challenges. So about a year ago, a year and a half, I started on Instagram and by myself trying to help clarify the pathways for internationally trained physicians, because I realized that not even Canadians understood the vast number of different options there were for licensure, and internationally trained physicians were lost in terms of which pathway to follow. And I was in a very comfortable and privileged position where I was already licensed, and I was able to follow a pathway that is quite uncommon in a way, because I got an academic license before I was able to take my exams and have a full license. And I completely understand and appreciate that that is the exception, that is not the rule. So I wanted to help people that were not able to get an academic license and go through other pathways. And as I started collating and having to learn about the pathways myself, I started putting all this information on a Word document, and when it reached 50 or 60 pages, I was like, I think this needs to become an ebook and be shared with everybody. And when I joined the MCC, we quickly put that together as an ebook. We created a table for clinical assistant and associate physician, and for the practice ready assessments to make it easy to compare the provinces. And by just disseminating information of what already existed, so many physicians already started getting licensed in itself. So I think that is the number one thing, is even just sharing what's already there. And then in parallel to that, we can advocate for changes. But it's even hard to advocate for change when you don't even fully understand the picture or how the landscape is. So I'm just going to start my presentation today about talking about licensing pathways. It is about an hour long, so brace yourself. I'm going to talk for a lot. And that is the reason for that is because licensing is complex. And one of the things that I have been pushing against is that when I do these talks, or when I, even at the MCC, when they go through my slide decks, they're trying to can we simplify it and put 3 or 4 pathways that applies to all provinces and and I said, there's no way. It's so complex. We're trying to oversimplify. And when we oversimplify, we eliminate some of the possibilities that might be the only possibility for a certain ITP in a certain province. So I do need to talk about all the options, because I don't know who's listening, and maybe that, I will mention an option that is for that person. And, while I'm talking, a lot of you will be saying okay, that's not for me, that's not for me. But eventually you might say, okay, that one would work for me. And that is why I'm going to go through all the possibilities. Okay. I don't have any financial conflicts of interest. If you follow me on Instagram, for those people that are online, I do speak my mind on Instagram, and when I'm on Instagram, I'm not representing the Medical Council of Canada or the University of Toronto. So that is my conflict of interest. But right now, and when I present at conferences, I'm always representing the institutions that I work for, which is the University of Toronto and the Medical Council of Canada. Okay, so I want to start by telling all internationally trained physicians that, as and resonate what our first keynote speaker said, you're not behind. And you do not need to feel that you don't have work. You are just in a different system. And you just, it's not because you board a plane in your country where you're fully licensed and you get out of that plane in a country you're not licensed, that during that flight, your knowledge or your experience or who you are as a person changed. And I think a lot of people forget that after they're here for a couple of years. They start feeling like they're not competent, that they're not trained, that they're not a physician even anymore. Some people say, I want to become a doctor in Canada. Well, you can't be a doctor. You're already a doctor when you boarded that plane. And I'm speaking mostly to physicians, but this applies to all professions. And the matter is, how do you show your competence so that the assessors and the population here feel safe with the care you're going to provide? And also, you need to take in consideration that when you go to another country, it's not only about the medical knowledge, it's about language, it's about culture, it's about the local regulations and policies in place. So I can't, even though I was trained in Brazil and I'm licensed in Brazil and in Canada, I can't simply board a plane, get out of the plane in Japan, and decide that I'm competent to practice, because I'm not. I can't speak their language, I don't understand their culture, I don't know the policies. And that does not mean that, if everything was known to me in an operating room there, so if I was to go into an operating room where everybody spoke English and I had, only Western trained physicians speaking and talking and acting the way I do in Canada, I would for sure be able to deliver an anesthetic there. But if you drop me in the middle of an operating room where, the physicians, the nurses, everybody has their culture, their policies, their charting, I would not provide a safe care. So that is why we, as internationally trained physicians, we do have our responsibility of learning that piece so that we can apply the competence and the knowledge we have to provide patient care here. And I think that is the integration that we need to fight for, is how do we provide tools for internationally trained physicians to do that transition, to learn what they need, to apply their training and their knowledge to provide safe care here. Okay. So why does this matter to me? So I arrived in Canada in 2017, and I know that looks like it's way more than 8 years ago, but it's only 8 years ago. And all I wanted was to be a licensed physician in Canada. Like that was my goal since forever. I'm not going to be able to talk about all my story here, but my parents immigrated to Canada when I was 7. And we went back to Brazil when I was 10 or 11, but I went back to Brazil as a Canadian citizen. And my dream was always to come back. But I stayed and did all my training in Brazil. So I've started researching, licensing pathways 4 or 5 years even before I arrived in Canada. And I started applying, sending emails to the Royal College, to Medical Council of Canada, way ahead of time coming here. And so when I came, I had plan A to Z, but it did not include going back to Brazil. It included staying in Canada no matter what. And I started doing a fellowship, which is a subspecialty training within your own specialty in simulation and anesthesia education. Shifted completely my career from research to education. And when I went to, I told someone at St. Michael's Hospital, I want to stay in Canada, and the only option for me is to get an academic license. And at that time, I had done medical school, 4 years of residency, Ph.D. I was doing my fellowship, and they said, you don't have nothing to become an assistant professor. And I was like, kind of like, reality check for me. And it's like, you want to go into education, your PhD is research. If you want to do, become assistant professor and work in education, you need to have a master's or a PhD or have more, training in education. So I was, very sad and cried for a week. And then I said, well, I can stay crying forever and not get the job, or I can just go and sign up for a master's. So I got up, signed up for a master's and did my master's at U of T in healthcare education. And then I came back after a year and I said, okay, now I want my job. And they gave it. So it was good. It was a learning experience for me. And it helped. I did understand that I needed to learn more about the education system in Canada to be in that role. But it is hard when you are doing so much education, or sometimes you feel like you've walked such a long path and you look to your side and you see someone who's had the privilege of doing all that here, and you feel like you have to overperform to be able to be at the same level or be recognized for what you already do. So this matters to me because I walked that path, and I want other people to be able to do the same. And I don't mean, do academic career or do a PhD and a master's and a fellowship. I just mean understanding that sometimes you just need to find out where you're going, know what is your goal, your target destination, understand what are the possible pathways, and then once you pick your road, just make sure that you complete every single step. And at the end, they will have to license you. And that's what you need to, I think the shift is not, we're not, as someone said, they're not doing as, it's not about pity or, that they owe us a favor, but we are competent. We will be able to show that we're competent. We need to understand the rules of the game, and then everybody here is very resilient and will do what's needed as long as it's possible and there is a pathway. And I can tell you that because the system is so complex, there are so many pathways that it's very rare to not have a pathway for a physician. I've been talking with people one-to-one. There's usually always a pathway. If it's not for full licensure, which is usually possible, there is at least a pathway usually for role in medicine, such as a clinical assistant or associate physician, where you'll be able to have professional realization, have a good income, and be in medicine and not be working in non-clinical jobs if that is not what you want. And I say that because a lot of physicians want to work in non-clinical roles, and that's completely valid. But I hear a lot of people that want the clinical roles and can't achieve them. So I'm more focused in helping people achieve clinical roles. And I know there's other people that have way more experience than me in helping physicians that are willing to go into non-clinical roles. So I'm going to focus on the clinical roles. So at the end of the session, you'll be able to understand Canada's licensure pathways and how they differ by province. I want to also explain a little bit about the role of the institutions, because that's really important for people to understand. I found it very interesting when our first keynote speaker mentioned that, there's this like you work through exams to become a licentiate of the Medical Council of Canada, and you think it's a license because it's called licentiate. And then a lot of physicians realize that it's not a license, and the license is a provisional, so is by the provinces. So that understanding even of organization before you start the process is really helpful. And by understanding the pathways, you might find out that you don't even need an exam. So I find a lot of physicians are taking exams, they don't even know what they're going to do with it after, because people just told them that's the way, just take the exam. So they're spending time, resources, not working, not being with their family, not traveling, doing all these things and sacrificing things they don't need to sacrifice when there's already a lot of sacrifice happening. So let's try to remove the ones that are unnecessary. So trying to help you identify the programs that might match your qualifications, the ones you already have, how to navigate provincial requirements using trusted resources, and strategically plan your next steps, no matter if you're a general practitioner, a specialist, or a subspecialist. Okay, so there's the overview. I'm going to talk a little bit about the Medical Council of Canada and our role in all this. I'll talk a little bit about nomenclature and why that's so important, why that's such a common issue for internationally trained physicians. I'll talk a little bit about where to start, and then the pathways for each of the groups. So general practitioners in family medicine, specialists, and then subspecialists. Okay. And I see a lot of people joining. We're 122 participants. So if you guys have questions on the chat, I'm not able to read the chat, but maybe if there's someone who's reading the chat and can let me know at the end, I'll save some time for questions and answers. So you guys can send the questions and answers on the chat, okay? So as I mentioned earlier, the MCC included assisting internationally trained physicians and international medical graduates as part of their strategic plan in 2024. And that was extremely important because it led to a lot of action happening after that, including creating a role for and a space for an internationally trained physician to join the Medical Council of Canada, which happened to be me. And it was a surprise to me. I never envisioned or imagined, especially when I was going through the pathways and taking the MCC QE Part 1 myself, that I would ever be in this role. I was invited, and it was a shock, and it was an honor. But the good thing is that I realized that I could bring that vision and help other internationally trained physicians. So the institution is taking steps towards that. And I think it aligns with the political landscape and the changes that are happening in the Canadian healthcare system, that we are in dire need of physicians. And Canada has now realized that we have this hidden gem that has always been there, these physicians that have always been around, but that can come into action way faster than opening 50 medical schools and increasing all the residency programs and waiting for, people that are now in grade 12 to become cardiologists or cardiac surgeons in 20 years from now. We have cardiac surgeons driving Ubers that might be able to be, operating on your family member, that we just need to help them, as I said, apply their knowledge and competence to Canada and the Canadian population. And that is much faster to do than to train someone from ground zero. So there is, as I said, when we get out of the plane, we're not competent to practice immediately, but that transition is much faster. And there are resources we can do and help that we can provide to assist those physicians in quickly becoming very competent to practice here. Okay. So how is MCC, the Medical Council of Canada, now supporting internationally trained physicians? So aside from my role, we have started to centralize a lot of information on the Medical Council of Canada. Historically, the institutions didn't really want to have a lot of skin in the game because there's always liability, right? Everything you put on a website, people are like, what if it's wrong? They're going to come back at us and say that we provide wrong information. And everybody's afraid of putting information on the website because it might be incomplete or it might be wrong. So, if you go to the Royal College or the MCC website a while back and you looked for immigration information, they would just refer you to the link of the immigration website. And then if you went to find out about, CARMS, link to CARMS website. And you want to find about link, and it's always to the very homepage of the other institution, which doesn't help a lot. If you're at the MCC website and you're looking for pathways for immigration, you're looking for pathways for immigration for physicians, and then you go to the immigration website, they're going to be talking as well for pathways for immigration for, forestry workers. So that has nothing to do with what you do. And for you to dig that information on top of digging information for every single licensing pathway, on top of digging information for everything, and putting all that together is overwhelming. It's time consuming, and everybody's repeating the same process. Everybody's doing the same exact thing and struggling to it and spending so much time and resource on it. So we we're trying to centralize information that are relevant to physicians on a single website. So we started by the ebook that I mentioned before, which centralizes all the information about clinical assistant, social physicians, and practice-ready assessment pathways. That is not all the pathways that are possible. So we started focusing on general practitioners in family medicine. So for specialists and subspecialists, the ebook is not as useful. Still, some of them may qualify for clinical assistant or social physician roles. And at the end of the ebook, we do talk about practice-ready assessment for specialists, but that is the exception for a specialist. So the ebook right now is mainly for general practitioners in family medicine, but that is the vast majority of our audience. And you can use the ebook to, understand the pathways, see which provinces match best with your qualifications. And then there are some links that are very specific for you to follow up on specific pathways. Aside from that, we're trying at the Medical Council of Canada to expand our preparatory products. So in the summer, for example, we will be providing 55 multiple choice questions that are examples and practice for international trained physicians free of charge on the website, so that people can understand how the exam is and understand how they're going to be assessed better before they challenge the exam. Okay. So one of the things that is important is to understand the structure of how licensing happens in Canada. And this is very important, and the vast majority of the physicians and the population do not understand how this happens in Canada. So I would like to very quickly explain this. So the Medical Council of Canada, the Royal College, and the College of Family Physicians of Canada, they're national organizations. So they're not provincial, they're national. And they're assessment and certifying bodies in the sense of they do not issue license. Okay, so even though the Medical Council of Canada can grant you a licentiate of the Medical Council of Canada, that is not a license. They do not have the authority to let you work as a physician in Canada. Okay, it's not their role. That is not what they're built for, they're licensed to do, or they're authorized to do. Their role is to assess your knowledge in either medicine as a whole, or a specific part of medicine, such as specialty, a subspecialty, or family medicine practice, and issue you a certificate. Say, yes, I assess this person, they pass our standard. That is basically what these institutions do. Okay, they do not issue license. Then we have the provincial bodies, the College of Surgeons and Physicians of each province, and those are the bodies that can give you a license. So they're called medical regulatory authorities. They, in Canada, they're autonomous in the sense of in a province, they are the ones who decide who can have a license or not. They do not need to match what other provinces necessarily do, although they tend at a high level when when you have a full license in one province, the other provinces will recognize that. But up to that point, they can have completely different requirements or eligibility or procedures for giving license. They can make their own licenses. So for me, it was interesting. In Brazil, there's 2 types of licenses all across the country. And here, only in Ontario, we have 13 different licenses. So I was like, what? There's 13 different licenses, each with different eligibility criteria, with different scope, in the sense of the physician that has one license and the physician has a different license. They might be authorized to do different things. One might be able to only work in an academic center, the other in the community. So there's so many different possibilities within a single province. Imagine that times 13, that it's just overwhelming. So it's important to understand that their national bodies are the one that I mentioned before. They assess you, they give you a certificate, and then the regulatory authorities in the provinces, they decide what they're going to ask from you from these national bodies. So they might say, you need to have the Ascension of Medical Council of Canada, you need to be certified by the Royal College of Canada, and then you can work. But they might also say, you do not need that, and you can still work. So they are the authorities. They can give you a license regardless of what the national institutions are saying regarding your assessment and the certification. And that distinction is important because I get a lot of people coming and say, when is the MCC going to change the licensing requirements? And my answer is never, because we don't do them. It's the provincial medical regulatory authorities that will change licensing procedures. And we at the MCC can talk about examination, assessment, like the practice rate assessments. We have a big involvement, but we are certifying and assessment bodies. We are not licensing bodies, okay? So nomenclature matters because we throw a lot of words around in these websites and the medical regulatory authorities, MCC, that sometimes have completely different meaning for people coming from abroad. So, and sometimes it's counterintuitive. So for example, I'll give an example. What is considered postgraduate training? So in Brazil, we do 6 years of medical school with 2 years of internship at the end of our training. And that internship is considered and valued as a postgraduate training, at least 1 year of those 2 here in Canada. But I haven't graduated yet. So it's counterintuitive. It's postgraduate training, and now they call it pre-diploma internship, but it's still considered postgraduate training. But to me, it's a pre-graduate training because I just hadn't graduated, but we still call it postgraduate training. So it's counterintuitive because I talk to a lot of IGPs. They're like, I don't have any postgraduate training. And I'm like, well, where did you train? And then they'll say, oh, they'll tell me the country. And how long was your medical school? 6 or 7 years. I'm like, well, you do have postgraduate training because, if you had gone to a school, for example, the Caribbean, where the schools are 4 years and there is no internship, you would have to have that postgraduate training after you got your MD. You would have to do that 1 year internship either in the US or in another country. And in your country, you already have to do it before you're even considered to be a doctor. So the nomenclature matters. It's important to understand that you might have training or credentials that you don't even know you have, and you're maybe not even applying for practice rate assessments because you think you don't have postgraduate training, and another requirement says you need to have 1 year postgraduate training in family medicine. And then you did medical school abroad. You have 1 year of internship in general medicine, which aligns with what they're asking, but because you don't understand what they're saying and they don't understand what you have in terms of training, there's a gap. And that person that is competent to practice or to go through the assessment that already exists in Canada is not applying for that position. So that's why clarifying nomenclature is so important, that that people that already have the credentials or the training and they're eligible for certain programs we put them together. I'll give another example. So what's considered independent practice? So independent practice is something people don't understand, and it's so needed because every time you go to apply for a license, they'll say you need to have, or you go to apply for a practice rate assessment, they'll say you need 2 or 3 years of independent practice experience. And then people are like, well, what is independent practice? In my country, I'm called a medical officer. I hear that all the time, or a house officer. What does that mean? So understanding what that means is important. And in the Canadian, terminology, when we're talking about licensing, independent practice means that you were the most responsible physician. So that means that if you complete your medical school and you have a license to practice in your country, and you went to a rural area where you were the only physician taking care of patients, diagnosing, managing, making decisions without supervision, that is considered independent practice. Even if you didn't have a specialty certificate, if you didn't do any residency training after your medical school, that is independent practice. Okay? Now, if you were in a supervised role, so you're doing residency training or internship, by definition, you are not independent because you're in training. Okay? And some terms are very commonly mistaken for each other because they are the exact same word, but they mean completely different things. So for example, it was a learning experience for me when I started working a lot of physicians come from countries that I had never worked with before. And I started, for example, now there's many colleagues from India where I work at St. Michael's Hospital. A lot of internationally trained physicians come to do subspecialty training with us. And they would say, I have an MD anesthesia. And to me, that meant, I didn't understand, like, what do you mean MD anesthesia? MD is medical doctor, which means you have a medical school. They're like, no, my medical school is MBBS. So I was like, hold on. And then I had to learn. You know, so in some countries, the medical school will be MBBS, which is a Bachelor of Medicine and Surgery. And then the residency training, they call MD, and then the specialty. So what we call MD here, medical doctor, which is medical school, they call residency. So I asked them when they went to my Instagram, the first question was, are you an MD? And they would say no. I'm like, why are you here? And they're like, I had did MBBS and I did my internship and I worked as a physician. I'm like, well, then you are an MD. They're like, no, I didn't do MD. So then, like, you know, that back and forth until I learned and I started using the correct language. So now I asked, did you do a medical school? And then people understand. And I say, did you do specialty training? So we need to change how we ask the questions, because if you go on the website and you ask, are you an MD? And they say no, that doesn't mean necessarily they're not a doctor. But we, like a lot of the people in charge of these institutions, don't even have that understanding, because it's not like, it's hard for us because we're not aware of how things are in every single country. Another example is internship. So internship for me was at the end of medical school, or as soon as you finish a medical school program, the first year of hands-on clinical experience, supervised training, where you rotate in different areas of medicine to gain clinical experience in all of the areas that are relevant. So usually most of the internships will have rotations in the big discipline. And then I went to talk to someone from Ukraine, and I said, do you have residency? I didn't ask their residency. I said, are you a specialist? They said yes. And then I said, okay, how many years of training? They said, oh, I have 2 years of internship. And I said, well, internship is not specialty training. They're like, yes, it is. They're like, no, it's not. And we went back and forth. And I found out that residency training in Ukraine, they call internships. So and then the internship that they do during the medical school, they don't call internship because the internship is after. So I had to explain to them, I said, okay, from our perspective, the way we talk about things, you did an internship during your medical school because it was a 6-year program, and after medical school, you did a residency training. You're like, oh my God, like at home, we say that I did a medical school and internship after. So it's the same training, the same, what they did is what many other countries do, but because they weren't able to put on paper and explain in the same words we understand, they were missing out on so many opportunities, because if it didn't say internship, they wouldn't apply for it. And when they submitted their documents to the Medical Council of Canada, they would upload it as internship, because there's an option there, internship, but it wouldn't be accepted because they needed to upload it as postgraduate training that is not internship, like residency training, and they weren't doing that. So there's a lot of us that we need to learn, and it's so hard because there are 190 countries doing different things in the world. So it is also a challenge for us. But if we educate not only the physicians coming from abroad, but also the people here, we can start breaking a little bit of the gaps just by changing or explaining the nomenclatures. Even within Canada, and for people that are already here, it's very confusing. So clinical assistant, physician assistant, medical assistant, associate physician, clinical associate are completely different things. And they sound very similar. So I get that all the time where people say, how can I become a licensed physician assistant? And I said, well, unless you go to physician assistant school for 2 years, you're not going to become a physician assistant. Well, but I have a friend that is a physician assistant. I said, no, he's a clinical assistant. Oh, but is that the same thing as my friend is an associate physician in another province? And it's like, yeah, similar. Oh, okay, so I can apply for a clinical associate job. I said, no, because that's independent practice. So like they don't understand, and it's hard because I even had to learn all these. So here's a table where we'll quickly go over that. So clinical assistant or associate physician is an internationally trained physician. And the reason why it's always internationally trained physician is because if you did your medical school and residency in Canada, you're eligible for full licensure. So you wouldn't be applying for these roles. These roles were created for internationally trained physicians. where your training either doesn't match what's needed for a full licensure, or you're not there yet. You need to do that transition to practice in Canada, but you are able to provide patient care under supervision. So you work under a physician with a full license, under supervision, which can be closer or more distant supervision, but you're not an independent practitioner. So you're not an independent practice, which I just explained a little while back what it is. Not all provinces have these licenses, which makes it complicated. So in Ontario, we don't have them. So everybody working as a clinical assistant is not licensed. So it's an unregulated profession in Ontario, but it's regulated in most of the other provinces. The role of clinical assistant, it was always clinical assistant, and then there has been a more recent transition to calling the positions in this role as associate position. So they are very similar, and they usually are mean the same thing. So clinical assistant and associate position are very similar in what they do exactly. I'll just put like just consider they're the same thing. So they're synonymous. Physician assistant is a completely different profession. It's kind of like being a respiratory therapist, paramedic, nurse. It's a different profession. It's a health profession, but you need to go to a physician assistant school to be able to become a physician assistant. Yes, the daily work is very similar to a clinical assistant associate position, but they're different professions doing a similar thing. So at internationally trained physician, if you want to become a physician assistant and do the certification or take the physician assistant board exam, you need to go through a physician assistant school. But if you want to become a clinical assistant or associate physician, you may be able to do it by just having your credentials recognized. So it's a different, two different things. Medical assistant is usually not a clinical role. You never need a license for it. It's usually the person that is in an office, a doctor's office, that will do, the appointment. Sometimes they'll check heart rate, they'll check blood pressure. They will help to, manage tests and orders and stuff like that, but they're not in a clinical role. You don't need to be a doctor. There is some other training that you can do. So you don't even need to be a physician to be able to be in this role. And now clinical associate is a term that varies a lot, but I've seen a lot of job descriptions that says clinical associate. And usually it refers to licensed physicians. So usually independent practice in a temporary or restricted role. And it's mostly used by hospital credentialing. So it's a term that we try to stay away from, but it's very commonly mistaken by as a clinical assistant or associate physician because it joins two words that are very similar. I'm going to talk a little bit about where to start. It's important to understand that licensing in Canada requires 4 big columns, and everybody has to have those 4 big columns. So I came up with a way of explaining this that I call the IMG-L framework. And IMG is easy to remember, and then we add the L for language. So I is for immigration. So you need to understand that you need to have some kind of immigration status. Either if you're a refugee, if you're a permanent resident, or if you're in a work permit, you need to be able to legally work and live in Canada. The second is the medical licensing part, which is what I'm talking mostly about today. The G is for gap. You need to understand that currency of practice is important, and you need to try and avoid as much as possible creating a big gap or being away from clinical work for too long, because it might be hard to afterwards break the gap and go back to being eligible for many positions. And language. You need to be proficient in English or French, depending on where you were applying for a job. If you don't have all 4 at the same time, it is going to be very difficult to get licensed. So you need to work on those at the same time. And I'm only talking about one pillar. And a lot of people kind of put aside, immigration, currency of practice, and language to work exclusively on the licensing part. And as other keynote speakers mentioned, when they finally reach all the requirements for licensing, because of the other 3 factors, because they don't have a PR, or because they didn't take a proficiency test, or because now they're out of practice for too long, the puzzle doesn't come together because you're missing other pieces, okay? So For language requirements, you can check the ebook. They're pretty standard for all the provinces. Physiciansapply.ca is managed by Medical Council of Canada, and that's where most of your credentials will be stored and verified. So that's a very important place to start. And about immigration, it's also very important to understand what are your options. We have now a part on our website that is called Where to Start for physicians. And there we list a lot of detailed information about options for immigration for physicians. We also list the language requirements and we explain what current skill practice means. So we're trying to address those before we talk about medical licensing, which you will find mostly on the ebook. Okay. I always put this disclaimer because it's changing so fast. I think in the last couple of years we saw more changes in licensing for international trained physicians than we've seen in the last 2 decades. Things can change without notice. So every time if you see something on the MCC website or something on the ebook that is different than the medical regulatory authority has on their website or on their news, you need to believe the person who gives you the license, not the person who's trying to help you get to them. So the ultimate word is always the medical regulatory authority. So they're autonomous, they are the authority when it comes to giving license. So if the College of, Physicians of BC says A and I say B, you believe them. What they're saying is correct. And we're trying to catch up and share that information, but we're now not afraid of making mistakes and we're still trying to share even if they might be inaccurate. But we will direct you to their website. And ultimately, when you apply, they're the ones making the decisions. And if they say something different than, your friend or what the MCC says or what the Royal College says, ultimately you need to believe and accept. And the rule is what the medical regulatory authorities are telling you. Okay, just to make that clear. So current skill practice is important. And I will talk a little bit about what breaks a gap. But basically, it's usually either going back home to practice independently. But slowly there are some options within Canada for specialists like doing a fellowship, for example. But for people that are general practitioners or applying for family medicine licensing, there are some ways now to break a gap by being a clinical assistant or associate physician in Canada and then applying for certain provinces for a practice ready assessment program. And I'll talk about that. So I'm going to go now into the pathways, and I know this was the main part of my presentation, but it's really hard for me to talk about pathways without having all this explanation first, because then I start talking about, internship or residency. People that might be from other countries don't really understand what I'm talking about. So for clinical assistant and associate physician roles, and for practice ready assessment in general, family medicine or for general practitioners, I would like to refer everybody to the ebook. So the ebook is available on the MCC website. It's free of charge. It's a PDF. We have been trying to update the ebook as changes happen. And because it's not yet a website, you do need to download it every now and then and check if the version you have is the most updated version. Because if we do a change, it's of course not going to update your PDF unless you download the updated version. And we're working towards making it a live website where you don't need to, be downloading the PDF multiple times, but that takes time. And I wanted to really put this PDF out as quickly as possible to share this information. So while we're working on the website for now, you might need to download the PDF multiple times to have the most updated version. But I'm giving some highlights here of some common situations and give you some pointers on where to go into the ebook, okay? So if you are a physician who did not take the QE1 yet, and you're not a licentiate of the Medical Council of Canada, there are some options. In Manitoba, you can apply to become a clinical assistant if you have the NAC examination, which is the OSCE from the Medical Council of Canada, or if you do their clinical assistant assessment program that only exists in Manitoba, and it's done by the University of Manitoba. So those are 2 options for you to get licensed without the QE1 as a clinical assistant in Manitoba. If you have more than 5 years of independent practice back home, so you practiced as a general practitioner or as a specialist back home for more than 5 years without supervision, so you cannot count internship or residency training. If you practice for more than 5 years, you can apply to become a clinical assistant in Nova Scotia, New Brunswick, and PEI without having the QE1. Okay. And because I am in Nova Scotia right now, Nova Scotia is the only one that accepts you to count training years as well to make up for those 5 years. So in New Brunswick and in Prince Edward Island, you need to have 5 years of independent practice. So it does not count training years. In here in Nova Scotia, it counts everything after you obtained your medical degree, or and also the year of internship. If you did a program that's like 6 years, it will count 1 year of that training plus your experience. So let's say you did a medical school that's 6 years long, and then you did 2 years of residency, and then you worked for 2 years. So you have 1 year of internship, you have 2 years of residency, and you have 2 years of experience. That makes up to 5. The College of Physicians and Surgeons of Nova Scotia, at the discretion of the registration committee, but if they accept those years, because it counts up to 5, they can accept, they may be able to give you a clinical assistant license without the QE1 exam or any other exam. In New Brunswick or PEI, you would have to show that you have 5 years of experience after, for example, your residency training. You complete your residency or your internship, or you were working without supervision and not in a training role either. Okay. For physicians that now have a gap, sorry, can we go back to that previous slide? Yeah, for physicians with a gap of more than 4.5 to 5 years, so you've been out of clinical practice for more than 5 years, you can still apply for a clinical assistant license in Manitoba. Okay, Manitoba is one of the provinces where physicians that have more than 5 years of gap can still get a license to be a clinical assistant, and that is important because that might be one of the ways to break a gap. Okay. Now, if you have a gap of less than 5 years, thank you so much. That's a sign that I'm probably talking so much. If you have a gap less than 5 years, you might have options in other provinces as well. So the reason why I put a gap more than 4.5 to 5 years, because when you reach that point, it's only Manitoba really that allows you to get licensed without breaking a gap. But before 5 years, you have other options. So between 3 and 5, there are some options for, especially for a clinical assistant and associate physician in many provinces. And I always encourage the physicians to really, the 3-year mark is a very big alert that you're going to start losing your opportunities in the next 2 years. So try to see what are the things that, how you can secure a license without delaying any further. And there are many, because then there's more options of places to live. Maybe you're already in a province where that is possible, but after 5 years, it's going to become harder. And then currently it's only Manitoba. For physicians that have no previous postgraduate training, no internship, no residency. So for example, you did a medical school in the Caribbean and you didn't do internship, didn't do residency, didn't do anything after, you can become a clinical assistant in Manitoba or Saskatchewan. Those are the 2 provinces that if you pass exams, you'll need exams. But if you pass the QE1 and or NAC, it depends on what province you're going, you may be able to be licensed in a supervised role, such as a clinical assistant or associate physician, okay? And for physicians that have never worked independently, but you might have done internship or residency, for example. So you might have done, you completed a 6-year program abroad where you did internship during your medical school, and then you came to Canada right after. You don't have independent practice experience, but you have that 1 year of internship. You may be able to be a clinical assistant or associate physician in multiple provinces if you pass one or other exam. So I think this is also something that a lot of people don't know, that it's really important. For a practice ready assessment, so what is a practice ready assessment? So a practice ready assessment, as the name says, it's an assessment to see if you're immediately ready to start practicing independently. Okay, so that is the role of a practice ready assessment. It is an assessment, it is not a training. Okay, so when you join a practice ready assessment program, you are assessed for a period of 3 months. And every day that you're there, you're being assessed. You're not being trained. Of course, you're going to learn in the process. We all learn all the time. But it's not a residency program. It's not a training program. You're not registered as a resident. You're not registered as a fellow. You are licensed with a provisional, even like the regulatory authorities will give you a temporary license to be assessed because you're being assessed. And if you complete those 3 months and they say, yes, you pass, they basically said you're ready to practice. And after that, you get a provisional license where you will be practicing independently, but it's provisional because you still will have some kind of limitation, either because you need to do a return of service for 3 years in a rural area, or because you will be assessed every now and then by like chart reviews until you go to a full license. But it is an assessment that will lead to an independent practice. Okay, that is the practice rate assessment. A lot of people have a misunderstanding that when they get into these programs, they're going to be trained or taught how to transition to practice in Canada, and that is not the purpose of these programs. Yes, that kind of happens throughout the 3 months, but ideally, you will come into that assessment having some kind of previous knowledge of what you need to do or what you need to know to be competent to practice in Canada. So I always recommend for physicians to work as a clinical assistant or associate physician in a supervised role for at least 3 to 6 months, so you can learn from the person who's supervising you, be in a role where you're not the one making independent decisions, so that when you come to be assessed, you're ready, and you don't fail practice ready assessment, because that will delay even further your licensing process. So to increase your chances in a practice ready assessment, you should at least try to work as a clinical assistant or associate physician, licensed or not. Some people in Ontario can't get a license in Ontario, but if you're with a physician and you work in that role for 3 to 6 months, your chance of success at a practice ready assessment will be much higher. Okay. So here are some highlights of what you'll find in the ebook. So there's some provinces where you do not need to do the QE1 to be able to enroll in the practice ready assessment. Nova Scotia has been leading in so many ways a change that Canada wants to see, and we're very I'm very proud when I see all these changes Nova Scotia has been doing, and I'm kind of honored to be doing this week here because I can say it. And when I go to other provinces, it's kind of like, oh, if Nova Scotia is doing this and you guys are not, it feels kind of weird. But I can say this because I'm here. But it is true. A lot of, the PACE program, which I think today there's going to be a talk later today. Another keynote speaker will talk about the program, how innovative it has been. But even for specialists, the way internationally trained physicians are being considered ready for practice has been different in Nova Scotia. And I think it's leading to change for other provinces. So in certain situations, you might not need the QE1. Currently, for a practice ready assessment in general practice and family medicine in Nova Scotia, you do not necessarily need the QE1. If you have it, it might be an asset on the selection process, but it's not a requirement anymore. Same for British Columbia and Manitoba. Now, in Manitoba, you do need to have NAC, which is the OSCE exam from the Medical Council of Canada, as opposed to Nova Scotia and BC, where right now you won't need to have any exam, or you can apply even if you don't have any exams. Okay. The NAC is the OSCE examination. There are multiple provinces that do not require that examination anymore, but some still do. Here's a list of the ones that do not require NAC. So British Columbia, Alberta, Quebec, Nova Scotia, New Brunswick. They all differ in other requirements. So I'm trying to group them by certain requirements that they have in common. You'll need to go to the ebook to understand what is the requirements, all the other requirements for each province. But some people that have not done NAC at all may be able to apply. It's just multiple practice rate assessments. There are options for people that are on open work permit. Most of the roles that require PR or citizenship will accept refugee status as well. But if you are not a refugee, not on PR, not a citizen, but you have an open work permit, there are still some practice rate assessments that not only might allow you to participate, they might help you secure a permanent residence status. There are some practice rate assessments that accept 1 year of postgraduate training. So historically, most of the practice rate assessment would require 2 years because that's how long family medicine training is in Canada, but there are many practice-ready assessments that accept 1 year if you have enough years of experience. So basically what they're saying is, the standard in Canada is 2 years for us to give the license, but if you have 1 year and you have 2 to 3 years of experience, we will, we understand that experience might have made up for an additional year of training, and we want to see if you're competent instead of looking just at your training. So they will do the assessment, the practice-ready assessment, the 3-month assessment, to see if you're competent. Because some people with 1 year and 3 years of experience might have reached the level of competency that is needed to provide safe patient care in Canada, and some people might have not. So you need to go through the assessment, but they allow you to go through the assessment. Whereas in the past, we were so fixated on you need 2 years of training that these people were left out. They were not able to show their competence. Some provinces still require 2 years of postgraduate training, and there are options for people who have never practiced, but they did 2 years of training. So similar to the way it is in Canada, where you do 2 years of training, some provinces mandate that no matter what, even if you did 2 years of training, you still need to have had independent practice experience. But there are some provinces that say no, if you did 2 years of training, we want to be you can be assessed whether or not you're competent, and we'll let you participate in our programs. Okay. So check the ebook for full details, and remember to download it frequently so you don't miss out on updates. So here is a pathway for independent practice. So I already talked about clinical assistant, and I talked about practice-ready assessment. The only part missing there is CARM. So it is an option to apply for residency training in Canada. That is managed through CARMS, and when I come to do my talks, I usually don't talk a lot about CARMS because there's a lot of information that has been historically the traditional route, as people would say. So people know way more about that than how to become licensed without having to redo your training or do your training for the first time here. So for that, I will refer you to the CARMS website. They have a lot of information, and I just want to highlight that it is very specific, not only to provinces, but to specific programs. So you need, and when I say program, I'll clarify that because again, nomenclature, I mean the specific discipline you're applying for in a specific university. So by that I mean, for example, if you're applying for family medicine at the University of Toronto, it will be different than applying for dermatology at the University of Toronto, which will be different than applying for dermatology at the University of British Columbia. So you need to look at the program, specifically the specialty and the university and the province. They have different requirements. So all of this is on CARM's website, and you can find that information. But it's pretty standard that you need to have both of the Medical Council of Canada's examinations, the QE Part 1 and NAC, to be eligible. And you usually need to be either in a refugee status or have permanent residency or be a citizen. There are exceptions. I have listed them there. So Quebec and Newfoundland might accept your LMCC to replace NAC. So basically, if you pass QE1 and you did at least 1 year of internship or residency, and you're able to get become a licentiate of the Medical Council of Canada, they may allow that to replace NAC. Quebec, since last year, has been the first province that allow people without the permanent residency to apply if you have an open work permit. And Nova Scotia, again, is the only province that accepts the USMLE Step 1 and 2 to replace the MCC QE Part 1. But you still have to take NAC. So if you did the Steps 1 in the US, 1 and 2 in the US, and you have the NAC from Canada, you're able to apply for CARMS in Nova Scotia only, okay? So now I'm going to talk about pathways for family medicine if you come from an approved jurisdiction. So approved jurisdiction is a term also that we throw around a lot. And I just want to explain that approved jurisdiction just means that, you know, a group of people selected some countries where they believe the training is very similar or the practice of medicine is very similar to what we already do in Canada. What the College of Family Physicians of Canada and what usually the medical regulatory authorities consider as approved jurisdiction for family medicine is not the same as what they consider approved jurisdiction for specialties. So that is confusing in itself, right? Because someone who's a family doctor, for example, in South Africa, will not be considered approved jurisdiction. But if they are an anesthesiologist in South Africa, they are considered approved jurisdiction. So the same country might be approved jurisdiction for specialty, but not for family medicine. And the opposite is also true. So for family medicine and general practice, the approved jurisdictions are Australia, Ireland, UK, and US. So if you are from one of those 4 countries and you did your training, you completed your training, you passed the board exam, and you got a license there, then you have a lot of options to practice in Canada, because the College of Family Physicians of Canada will give you the certification. So they'll allow you to use the term CCFP, so that you're certified by the College of Family Physicians of Canada without doing any examination. So that really speeds up your licensing process, because the medical regulatory authorities see that certification as a testing that you're competent to go to start your practice. So they'll give you a full license right away. If you did your training in the US, there are multiple provinces that will allow you to be licensed directly. If you did not do your training in the US, but you're certified and licensed in the US, so for example, you did your training in Brazil, you went to the US, you did all the steps, you did everything needed to work and be licensed there, and you're already working in the US, the only province that will assess your situation and may grant you full licensure is Nova Scotia. So you can apply, the registration committee will see where you're practicing, what's your experience, but they may, it's up to their discretion, but they may issue a full license, as opposed to all the other provinces require your training to have been done in one of these approved jurisdictions. Also innovative in Nova Scotia is that if you have a registration and a full license in Australia, UK, or New Zealand, no matter where you did your training, if you have your register and you do have a full license there, Nova Scotia will give you a defined license. A defined license is an independent practice license, where they will assess you for a period of between 6 months and 24 months, and then make a determination whether or not you can move to license without supervision and without expiry. Okay, so for example, if you're licensed in New Zealand, the only province that would allow you to come and already get a license without doing any exams or anything is Nova Scotia. So that's why when I try to, people try to simplify things, you might miss people. So, if someone's listening, they're like, oh, I'm licensed in New Zealand, even though I did my training in India, they could come to Nova Scotia without any exams and not have, the gap or be out of practice and then lose that opportunity. So now I'm going to quickly talk about specialists and subspecialists as the end of my presentation. I just want to say that for subspecialists, it's really hard. It's the most difficult group of physicians to get licensed in Canada as of now. So I will talk a little bit about that. So as I said, what is an approved jurisdiction differs between if you're a family doctor or if you're a specialist. But this that I'm going to talk now is for any country. I'll talk about approved jurisdictions on the next slide. So no matter what country you come from, you can ask the Royal College to assess your training. And when they do this assessment, they're only looking at your training. So someone who just completed a residency or someone who's been working for 20 years, they only look at your training. They're not going to look at anything other than your training, okay? So they're not looking at your experience. They're not looking at anything else. If they consider that your training is similar to the Canadian standard, they will give you what we call eligibility. The exam eligibility basically means you can write or Royal College exam. That's all it means, okay? However, after the Royal College, that national body that only assesses and certifies and does not give license, but if they tell you and give you a letter saying you can write your exams, just with that eligibility, some of the provinces will use that information to allow you to get a license. So Nova Scotia, for example, was the first one to do that, where if you have the eligibility, even if you don't have any of the Royal College exams, you can have a defined license. In New Brunswick, PEI, and Newfoundland, it's called provisional license. And when you get that license, it's independent practice, but you're supervised. So you need a job offer. But after 6 to 24 months, you'll be able to move up to a long-term license that is not supervised. If you pass your exams, then other provinces also will use that information that you got eligible and you passed exams to allow you to work. And there's a common misconception that after you pass your exam, so if they allow you to sit the exam and you pass the exam, that you become a fellow of the Royal College, and that is not true. You need to have worked 2 years in Canada in addition to passing the exams to become a fellow. But you do not need to become a fellow to be able to start working. Okay, maybe just with eligibility or with eligibility in the exams, you might be able to already start practice and not create a gap. Okay, be current in practice. If you're not eligible for practice eligibility, so let's say your training does not meet the Canadian standards, the Royal College does not grant you eligibility, there are some other options which are usually the exception. But you can go to an academic license if you're if you're offered a job at a Canadian medical school or university. You might be able to get a special license in New Brunswick. If you have 2 years of fellowship, you might be able to do a pre-licensure assessment in Saskatchewan, which is basically a practice-ready assessment for specialists. Or you may be able to do a practice-ready assessment for specialists in Alberta, Manitoba, Quebec. Nova Scotia typically always had a practice-ready assessment for specialists, but because of all the changes with how they accept eligibility and all that, that program has kind of stopped. I don't know if it stopped completely, but it's mostly Alberta, Manitoba, Quebec that is doing that right now. Next slide. If you are a subspecialist, it's pretty much the same. What I'd like to highlight is that if you get eligibility by the Royal College in your primary specialty, that's usually the best way to start in Canada, in your primary specialty instead of the subspecialty. And if you do a fellowship in Canada that lets you sit the Royal College exam in the subspecialty and you pass those exams, most of the provinces will allow you to practice in the subspecialty that you did your training in Canada, even if you're not licensed to practice in the primary specialty. So for example, you did neonatology, 2 years of neonatology fellowship in Canada. You set the Royal College exams for neonatology and you passed. Most of the licenses will allow you to practice in neonatology, even if you're not allowed to practice in pediatrics, general or core pediatrics. So you would be able to practice as a subspecialist. Okay, that's called CEAP. And you guys can afterwards, I think they'll provide the recording, look at the slides and have a little bit more information. If you're not eligible for PER in your primary specialty or the CEAP in your subspecialty, the options are pretty much the same as I said, as for specialists that are not eligible for the PER. So you can still apply for academic license, special license in New Brunswick, or do a practice-ready assessment in Alberta, Manitoba, Quebec, and Saskatchewan have the pre-licensure assessment. I think that's my list. If you're from an approved jurisdiction, so the list of countries are here on the left. These are usually the countries that are considered approved jurisdictions. It will differ by specialty, so you do need to access a document of the Royal College because it differs by specialty, and some of them is only after a certain year that they accept. So you need to have completed your training after like a certain year. But if you're from one of those countries, the most recent change is that Alberta will give you a full license right away. I believe that other provinces, such as Nova Scotia and BC, are going to move in that direction very soon. But if you're not able to go straight for a full license, most of the provinces will allow you to get a provisional license, and after a certain period of time, you're able to move up to a full license. Okay? And if you're trained, certified, and licensed in the US, many provinces are giving you full license right away. This is a recent change as well. Okay, and this doesn't matter if you're a specialist or a subspecialist. It applies for both. Okay, that is the end. I'm sorry it was a very long presentation. I only left 7 minutes for questions and answers, but I'll be happy to entertain any questions that I can answer in that period, that time. My Instagram is there. I respond a lot of questions through my question boxes on my Instagram, so feel free to send your questions to me there. And follow us also on the Medical Council of Canada Instagram, because we will post information about programs there as well. Thank you so much for listening for so long.
Okay. Awesome timing, Dr. Filipe Santos. All right, so we do have some questions here, and I'll start with one pertaining to recent of practice.
Yep.
And especially within PEGASUS as well, we do have quite a bit of international educated medical professionals who have fallen out of recent of practice and are of refugee status, cannot go back to their country of practice. Are there any strategies to navigate this process?
Yes. So it depends on how long the gap has been, okay, or how long they have been out of practice.
Okay, so give us some timelines, because I can tell you we have from 10 years out of practice. We have some with 5 years. It varies.
Okay, so less than 3 years or 2.5 years, less than 2.5 years, you can still participate in most of the practice ready assessments, which will lead. So I'm only going to talk. Do you want me to talk about general practice and family medicine or specialists as well? Because it's different.
Okay, so the main pathways. So we look at PRA, and for those who know, most times the province they last for 24 months, 36 months.
Yeah, but you're talking.
Right.
So you're talking about general medicine. So and family. Okay. I'll talk about specialists.
The specialties. So tell us about general medicine.
Yes. Okay. So I'll talk about specialists later, but for you to participate in practice ready assessments for family medicine, they usually require that you have practiced within the last 2 to 3 years. That is the pathway to full licensure that exists. However, if you're between 3 and 5 years, you're able to apply for clinical assistant or associate physician in most of the provinces. And if you work as a licensed clinical assistant or associate physician in any province in Canada, excuse me, but it has to be licensed, so Ontario doesn't count, for example. There are 2 practice ready assessment programs, 2 provinces that are accepting that time as a licensed clinical assistant or associate physician to break the gap. And those provinces are Saskatchewan and Ontario. So for example, you have 4 years of gap. You're not eligible for any practice ready assessment program at this time, but you are eligible to get a clinical assistant license in Nova Scotia, for example. You become licensed and you practice for 6 months in Nova Scotia as a licensed clinical assistant. You broke the gap for practice ready assessment Saskatchewan and practice ready assessment Ontario. So after working here for 6 months, you're now eligible for Ontario and Saskatchewan, and you weren't eligible before. So that's a way to break the gap. Now, if you have more than 5 years of gap, which means you're not able to get a clinical assistant or associate physician license in most of the provinces, the only option in Canada to break the gap is to become a clinical assistant licensed in Manitoba. So Manitoba does not look at gap, no matter if it's more than 5 years, 5, 10, 20. If you get a job as a clinical assistant and you get a clinical assistant license in Manitoba, that would break the gap and allow you to apply for the practice ready assessment in Saskatchewan or Ontario if you fulfill the other requirements. So you still need to have at least 1 year of internship with the rotations they require. You need to have 3 years of experience if you only did 1 year of internship. If you did 2 years of training, so 2 years of internship that they accept, or you did 1 year of internship and 1 year of residency, or you did 2 years of residency with the rotations they accept, then they might require less experience. Saskatchewan will not require any experience, and Ontario will require only 2 years. So for Ontario, 1 of training plus 3 of experience, or 2 plus 2, 2 of training, 2 of experience. In Saskatchewan, 1 year of training plus 3 of experience, or 2 years of training, no experience needed. So if you have a big gap, but you have previous experience or previous training, but you have a 10-year gap, and you go to Manitoba, become licensed there for 6 months as a clinical assistant, you're then eligible for Saskatchewan and Ontario to do the practice ready assessment. And if you pass, you have a full license. Or you have a provisional license that will lead to a full license.
Okay, awesome. So you mentioned for general practice there, that's good. And we do have some other questions pertaining to that. I see Vera Tao has her hand raised. Vera, I'm going to ask you to unmute your microphone and ask the question, please.
Yeah. Yes. Thank you for the chance for asking a question. Like my question for Dr. Sandhu is like you mentioned just now, like if we we can practice as we can get a clinical assistant license to break the gap for the PRA, but for the PER, can we do that? Does it apply for the PER?
You're talking about specialists.
Yes.
Okay, so PER, that's why I said it was different. So now for specialists, if you have the PER eligibility, so to get the PER eligibility, they do not look at gap. Remember that I said they only look at training. They don't look at experience. They don't ask English proficiency test. They don't look at anything else aside from your specialty training. If you're eligible, if you've got eligibility,
yes,
for your, so you got the PER eligibility, and now you got a job offer, but you've been out of medicine for more than 4 years and a half.
yes.
Then the only way to break the gap as a specialist currently is going back home. So if you reach 4.5 and you're a specialist, you cannot get a defined license or a provisional license or do any of the routes for a specialist if you don't go back home for at least 3 to 6 months. Now, you may be able to, so some of the specialists are able to go through the practice ready assessment in family medicine if they decide to be family doctors in Canada. But if you are a specialist and you're hoping to get, go through the specialist pathway, you have options up to 4.5 years out of practice. After that, you will need to go back home for 3 to 6 months at this time. There's no alternative that I know of in Canada.
Okay, so the gap is like 4.5 years, not 3 years.
Yeah, 3 years, you can still usually, most of the medical regulatory authorities will give you the license if you fulfill all the other requirements. So for example, in Nova Scotia, if you find a job offer and you have the eligibility, you're eligible for a defined license, the registrar will usually issue a defined license if you're with, if you have practiced within the last 5 years. So if you have practiced for at least 6 months within the last 5 years. One of the options that you can use to break a gap is a fellowship program. So if you do a fellowship in Canada, that is considered training, it breaks the gap and you're allowed to then get a license. So let's say you have 5 years of gap, but you're able to get it, be accepted for a fellowship program, and you do that fellowship for 6 months at least, you can then, you become eligible again for licensure.
Okay, thank you so much.
All right, awesome. So we do have quite a bit of questions here in the chat. We're not able to respond to all of these questions in the interest of time. So Dr. Santos, I'm not sure if that is okay with you.
Yeah, of course. Yeah, thank you so much. I want to thank everybody that was online.
Continue, then that would be awesome. Thank you. So thank you so much for this very informative, power-packed discussion that you've had, and also responding to the questions from our participant at this time. So I'm going to be inviting our next speaker to join us. So we have Beverley Zwicker. Okay, I hope I pronounced it name correctly. Okay, awesome. Now, she is the CEO and Registrar of the Nova Scotia College of Pharmacists. With over 2 decades of experience in pharmacy regulation and practice, she has been very instrumental in advancing regulatory modernization and workforce integration in Nova Scotia. She has played a role in efforts to streamline licensure pathways for internationally educated pharmacy graduates, aligning regulatory framework with public health needs and equity principles. Under her leadership at the Nova Scotia College of Pharmacy, she has championed collaborative approaches to address healthcare system challenges and enhance patient care. Beverley is widely recognized for her commitment to innovation, professional standards, and of course, fostering inclusivity within the pharmacy profession in Canada. Audience, please help me welcome Beverley Zwicker, who is being presenting.
Thank you, appreciate that. Thank you very much. Nova Scotia College of Pharmacists, and so we are the regulator of the profession in Nova Scotia. So we'd be the equivalent of the MRA We call ourselves the PRA, Pharmacy Regulatory Authority. And I thought I'd begin by, if you want to just advance to the next slide, starting at about the 50,000 foot level, just to give a sense of like, I really appreciated the previous presenter saying there is the national associations and then there are the regulatory authorities. And how does this fit in our societal framework of providing safe care to patients? So professions have a social contract whereby the public gives certain individuals an exclusive right to provide care, to have a very, sometimes a very lucrative occupation, where only they can perform these activities, only they can have these career jobs. And in exchange, the profession gives an assurance that that care is going to be provided safely, that there will be quality, and that there will be ethical expectations for anyone who's going to provide them that care. The regulatory authorities, they sit as the organizations that fulfill that contract and make sure the professions are fulfilling that contract of the care is going to be provided in a competent, safe, and ethical manner. And there's a number of ways that regulators do that. It's a very multifaceted approach, but one of those key pillars in assuring safe, quality, ethical healthcare is licensing. It's that aspect of making sure that the individual actually has the capacity to competently and ethically provide care. So with respect to licensing requirements, they're established with the goal of enabling the regulator to be satisfied as to whether the individual who's applying has the capacity to competently and ethically practice. And the requirements are established as safeguards for correctly making that determination. And they typically, for at least in pharmacy regulation, we think of them in the areas of professional education. Is the core education sufficient to give people that foundational understanding that they need? A competency assessment, which is aimed at making sure that a person who has completed the education, it has had the intended impact, that they truly have gained a competence to be able to perform entrustable professional activities. Character, does the person have the character to be able to ethically provide care to patients in a way that's in the patient's best interest? Practice and system rules. Does the individual understand the system in which the care is being provided? I appreciate Dr. Santos, he indicated that you can have knowledge and education from quality education from another country, and it is provided in a way that enables that person to apply those knowledge and skills consistent with what that person's role is in that country and within the system and that broader system of safeguards. So it's really important to understand what is the framework, particularly for Nova Scotia, what is everyone's role and where are those safeguards to make sure that that's understood so that a framework of safety is maintained. Language proficiency is a key part of that. And then continuing competence, that currency of practice. And there was a lot of conversation in the last session just about how do we do that. So these are the areas that licensing requirements are aimed at making sure are addressed. So as the regulator, again, we have a mandate to assure safe quality practice. And when it comes to licensing, we have a responsibility to ensure that we license all who have the capacity to competently and ethically. For us, it would be practice pharmacy in Nova Scotia and wish to do so and to only provide a license to those. So we've been really good at the second part. We only provide licenses to those, but in reflection, we realized we may not be hitting the mark on we're giving it to all. The reason is that in meeting this responsibility, licensing requirements that assure only those professionals who have that capacity, you can put the bar really high in a number of ways. But in ensuring that you license all who have the capacity, you need to make sure there are no inappropriate barriers in place that are preventing those who have that capacity from being able to. And there's been research over the last several years in the area of how to effectively assess the competency of an individual that really it positions us to be able to do better in the first. And it's slowly being adopted. And I would say in pharmacy, certainly in Nova Scotia, we're the first province to be taking a look at it and saying, okay, how do we meaningfully take that research and bring it to our work so that we are widening the door to the profession without lowering the floor? Because there's a lot of people who think, oh, you're going to modernize the pathway, somehow we're creating risk. It's imperative that we don't create risk, and it's certainly possible to do that. I would go further and say that bringing research and evidence of how to better effectively assess the competence also enables the regulator to do a more effective job in assuring those requirements are met for those who are trained in Canada as well. So this isn't just about making provision so internationally trained graduates can now have access. It's actually bringing evidence base to improving our systems generally. So for us, that means adopting in a trustable professional activity-based programmatic assessment of competence to practice in real life care versus completion of some of these high snake snapshot examinations. So, you know, that has been our mainstay, our one and only tool, if you will, in our toolbox of assuring competence. And so I'm going to be sharing just a little bit about the work we're doing to do that. As we do this work, we have as one of our values that we will keep equity at the core of our work. And so in our work to modernize license pathways, we realize that keeping equity at the core of our work means that as we modernize these license pathways, that we need to commit to ensure that we are widening the door so that it's accessible to refugees. Because there are unique challenges for people who are refugees that if we don't intentionally address them, these pathways will not be accessible to them, while always making sure we're not lowering the bar. We can't lower the bar, but we can widen the door. So this has us looking at the requirements established for those different areas. This is a bit of it's a quick summary chart. So, you know, it's simplified. So it's not comprehensive, but just to give a sense, here's those down the left. These are those areas that we said that we need to be turning our minds to: the education, the competency, the character, their understanding of rules of practice and our system, language, and continuing competence. In the first column, this is sort of our traditional licensing pathway. To ensure education for those, when we're looking at inside Canada, we have a national accreditor of programs. For competency, we have, so the equivalent of the Medical Council of Canada that was just here, we have the Pharmacy Examining Board of Canada. So they are the national organization that we conduct our certification exams. For character, we require criminal record check. For understanding rules of practice, we have an open book JP exam, jurisprudence exam. So all of our standards of practice and our regulations are on our website, and we have an exam. We expect people to understand how to navigate, where to go to understand where the rules are and understand that there are rules, and so it's an open book exam. Our language, depending on if you're a Canadian, we trust that because you've gone through the Canadian program that your language is addressed. And then our continuing competency currency, we have structured practice experience. So then if you look at the next column that has, again in black, because this would have been our traditional. If you were licensed outside of Canada, for a long time, we considered everyone to be a homogenous pool. And there was only one license pathway. You had at the PEBC, you had to do an evaluation exam to determine whether or not that core foundational education was equivalent. You needed to pass the PEBC certification exams, which were really written to be completed by people who just completed their Canadian programs. You need your criminal record check, the JP exam, the language policy. So that is it's an IELTS 7 for all areas except for writing, which is a 6.5. And then we had internship modules. Recently, so the Patient Access to Care Act was created in Nova Scotia in April of 2023. And that was legislation introduced by the government to allow the regulators to have the authority to more nimbly address licensing requirements that we would identify need to be addressed in order to ensure the public interest is served, in order to ensure that we are able to license all who have the capacity to competently and ethically practice. And it allowed us to get into the reality of the international community in terms of where people are trained to be a pharmacist is not homogeneous. There is a wide variation. And so right off the bat, we were able to say, okay, there are in the US, Australia, New Zealand, UK, and Ireland, we looked at those jurisdictions, their education, their competency assessment approaches, their licensing structure is substantially equivalent to Canada, and we can trust a license provided to a pharmacist in any of those countries as assuredly as we can a license provided by Ontario or Manitoba or BC. And so for those countries, we consider that license to be equivalent. All you need to do is write the JP exam, because that's what the Canadian provinces have to do as well, and you can be licensed. We identified that was low-hanging fruit, and that more work was done. There's a broader international community. And so in looking at the broader international community, we recognize there's an easy path forward and there's a road to better. And one of the sort of value statements or guiding principles that we work by at the Nova Scotia College of Pharmacists is that the road to better and the easy path forward are two different roads. And the road to better is always worth the effort. So we're on the road to better. We began work in just in December 30th of this year to create a policy that we are piloting. So I appreciate some of no more pilot projects. Let's have pilot policies. So we're with you. So we created a pilot policy that has us right now. We're focused currently in Jordan, and we've been there 3 times. I've met with all the schools, looked at all the programs. We've done a tremendous amount of work, and I'm pleased to say that we are piloting a policy that is looking at alternative ways to look at education. So there's international accredited bodies. The ACP is the American, and we also are Canadian, does provide international, but a lot of the programs currently in Jordan have ACP international accreditation, and we work with subject matter experts to confirm what we can understand from that accreditation, what that means in terms of what we know about the education. In looking at competencies, we realize, again, this is where we're bringing forward what we, the research around entrustable professional activities, and we've identified that rather than looking at surrogate markers or indicators of whether somebody who's completed a program and completed a certain amount of practice is competent, we will assess the individual. And so rather than making assumptions about how much time should or shouldn't that person have practiced, this is particularly important for people who are refugees, because in countries such as Jordan, there is a surplus of pharmacists, and they are actually, it's a closed sector. So if you are not Jordanian, you can't get licensed in practice. So you're completing your education. There are ways that you can practice. You can volunteer. You know, there's arrangements that can be made, but certainly nothing that would be easily documented and being able to provide to the regulator. So we stepped back and looked at that and said, okay, why do we require that? We require that because for us, it's an indicator or an assurance of currency of competence. What if we just assess the individual? So we actually have a screening that we conducted in Jordan using sort of a simulated OSCE type of assessment. We just completed that in May. So we are to screen applicants for a level of competency that we would believe would position them well to be successful. When you continue on, the second part is a practice readiness program. So what we've developed is a programmatic assessment approach for our practice readiness approach. So there is orientation, there is training in how to bring those knowledge and skills and apply them to the role of pharmacists in Nova Scotia, because the role of pharmacy in Nova Scotia is very broad. It's leading globally in terms of how pharmacists are bringing their knowledge and skills to providing care. So it's a very attractive place to practice. And so our practice readiness program is both an orientation and a training for how to do that. and as well, so we say formative assessments and mentorship, and also trained assessors, independent, that are providing summative assessments along the way to mark how is that person progressing towards independence in entrustable professional activity. So I'm not going to get into the weeds too much, other than to say, really standing up a program that is, for now, we're certainly focused on its utility for assessing the competence of internationally trained pharmacists, but we certainly see that as, looking forward, this is perhaps the way that we should be looking at assessing all applicants for licensure, including those who are trained here. And those are conversations we're having at the national level, but it's still early. But just to say, this isn't lowering the floor. This is bringing evidence to how we approach it. Character, we're looking for immigration purposes. IRCC does an extensive, again, because these are individuals who are screening before they ever come to Canada. So we're doing that work in the home country, so that when people are then coming here, they have an assurance of licensure and employment. And so then the last step is immigration. And I would say, I'm looking forward to the panel later. There's a narrative out there that the regulatory bodies are the barrier. I think there's a lot of work that we could do around aligning with immigration as well, because I know we've done a lot of work to address licensure barriers, and there's people are still struggling with some of the immigration challenges. So I think working regulators and immigration, IRCC working together, which we are on this project, I think is really critical. Okay, so the road to better, a modernized licensing pathway. It is work. So like I said, we've been, it's not quite 6 months. We've approved a policy. We are implementing the policy. We've had our intergovernmental meetings. We've met with the schools. We're collaborating. The schools there are also interested in how they can stand up some programs or have some resources to better enable people to be successful. So the collaboration with educators, immigration, employers, it really does take, it's a complex issue, and it really takes everyone working together. It's not just the national, like the Medical Council of Canada or PBC. It's not just the regulators. It's not just immigration. It's let's come together and figure this out. It is a solvable problem. It is a path to better, but it does take work. I just put at the bottom, there's the chart that at a high level maps out what we're doing. So we're pre-screening on the Jordan side for both competency and employability. In between, we're actually doing some pre-departure orientation and training. So there's English training in sort of curated for pharmacists, as well as some training modules to help understand what is practice going to look like here. How do you take what you've learned in pharmacy in Jordan and bring it forward to how you will be expected to provide care in Nova Scotia. We're also going to be working in the communities to prepare the pharmacies and the communities for accepting and embracing internationally trained pharmacists into their communities, because we realize that's a big part. And working with our settlement support people as well. So when the newcomers from Jordan arrive, they will have the wraparound supports they need, because they're both transitioning to providing care in Nova Scotia and to settling in a new country. And where those who are refugees, with all of those other challenges that they're bringing, given their history. Another truth that we keep in mind is that refugee is not something that it's not who people are, it's what's happened to people. And so, recognizing that a lot has happened to people who have refugee status, that you also need to keep in mind for them, and as a regulator, for the care of the patients that they're being provided. Happy to take questions. I would say that just thinking about some of the sessions that we've already heard, the why in this is really important. And I think it's really important to emphasize that this isn't just about addressing a workforce shortage. This is about strengthening the diversity of our workforce, which will make us stronger and better in terms of care provision to patients. what we've already identified is individuals who are trained in other jurisdictions. It's not like they need to come up to our bar, and our bar is the highest bar. Many have training in some areas that exceed what we provide here in certain areas. Coming together and sharing with each other and sharing what we've learned in terms of practice providing care makes us all better clinicians, and it makes us better care providers. In addition, as somebody also identified, we live in a diverse population. People, when we worked with the public, they said, we would value if there were people who had more of our experience providing us with care. So in diversifying our pharmacy workforce, we're actually doing what we should be doing in meeting the public's need for quality pharmacy care, and that is making sure that there's representation of their needs and their experiences in the healthcare workforce. So I just wanted to flag that. So right on time, 11:40.
Right on time. Okay, so Beverley, we do have it's more of a statement and then
Okay.
a question here.
Sure.
So this one is I'm a registered pharmacist intern with Nova Scotia College of Pharmacy.
Yep.
Living in Sydney, and I'm struggling to secure a place to start internship. So we're looking at strategies to facilitate students or to guide students to secure a place to start their internship here in Nova Scotia.
Yes, so we have multiple partners that we've been working with, including our Department of Health and the Pharmacy Association, and there is an initiative called RxNS.ca. The Pharmacy Association has somebody who's helping to link people to opportunities, so that is something that might be a resource for them. It's hard to answer a question very specifically on the fly, but I did want to flag, and I appreciate the question. This is a pilot policy, really important, but it is very specific right now to this cohort. Once we have implemented it, we've learned, then we will be looking at how do we scale it up broadly. But right now, it's just for this particular initiative that we have. It will inform what our licensing pathways will be broadly going forward. But for right now, what I've just described is just for those that candidates that we're recruiting and bringing here in the fall from Jordan.
Awesome. In terms of those countries, so you mentioned Jordan.
Yep.
This person says Sydney, so I'm thinking that person is in Australia. Are there any programs that or other countries that tie into that program?
Sure. Yeah, so I think Sydney might actually be Sydney, Nova Scotia. So I'm thinking that person is actually
okay.
Sydney. I think they're in Cape Breton.
So tell you, I'm from Ontario. I'm sorry.
That's okay. You'll forgive me for that.
Awesome.
Yeah, and I would also say, before I step away, I will make a plug for. I know that people think a national licensure is so complicated. If there was one license, that would be so much better. I would strongly encourage you to think carefully about what you're wishing for, because one national licensure means one set of requirements, and it would not enable the innovation and pathways, for instance, that Nova Scotia is creating. You would need to get consensus of all the provinces. So you think we want national because we want everyone to give us all of the innovation. That's not likely the way that plays out. So I think enabling every province having the authority to create pathways sets up Canada to be innovative. One province does it, another gets to adopt it. So I just wanted to highlight that.
Okay. All right.
Thank you.
So thank you so much. All right. Awesome there with that presentation. And you see a lot of changes happening somewhere in other places, in other professions. All right. So now I'd like to say with that closing note, awesome there. So opening the door for others to enter, but not necessarily lowering the bar. All right, and that's a very good statement there to close on. So at this time, I'd like to take the opportunity to introduce Dr. Harinder Sandhu, and he's the president and chair of the Royal College of Dental Surgeons in Ontario. And Dr. Sandhu brings decades of leadership and dedication to the dental profession. a very respected figure in Canadian dentistry. Now, Dr. Sandhu has made significant contributions to education, regulation, and community service. He has served as the Dean at Western University at the Schulich School of Medicine and Dentistry, where he also held roles as Chair of Admissions, Chair of Periodontics, and the Vice Dean as well. He was instrumental in launching the DOCS, which is Dental Outreach Community Service Program, which expanded access to care for underserved populations. Dr. Sandhu is a passionate advocate for accessibility in oral health care and was recognized in 2013 with the Queen's Diamond Jubilee Medal for his service to the profession and the community. He maintains an active periodontal specialty practice and has published numerous papers on clinical outcomes of periodontal procedures. Audience in person and those online, Dr. Sandhu will be presenting virtually. Please help me welcome Dr. Sandhu, our next speaker.
Thank you very much for a kind introduction. Good morning, everyone. Thank you for having me here today. I'm honored to speak to this group. You are the people who make a difference. You help internationally educated health professionals build new lives in Canada. Your work really matters. I have been introduced as president of Royal College of Dental Surgeons of Ontario. I'm in my second term now. We are the regulatory agency for dentists in Ontario. We set education standards, produce guidelines and standards of practice, and provide a complaint and investigation process for the public. Before I go into various pathways for internationally trained dentists, I should tell you something about myself. I am an internationally trained dentist. I understand the journey. I have lived it myself. I came to Canada in 1975. At that time, I had already practiced 2 years in India at a government health center after completing my Bachelor of Dental Surgery from Guru Nanak University, Amritsar. However, in Canada, I discovered that my degree from India was not recognized. I had to work very hard on myself to integrate into the Canadian system. Earlier, Dr. Santos have mentioned it is not only important what you know clinically, but I think integrating in the system is very important. Language is important, getting along with people and interacting with other professionals are the key ingredients for success. So I was very fortunate that I got a Medical Research Council of Canada fellowship to do a Ph.D. at University of Ottawa, and then a periodontics training at Loma Linda University, California. So this education opened the doors for me to become a periodontist and an educator, but I did go through some national board examinations in US as well. So my clinical training was assessed through my postgraduate training and some examinations. I want to focus now on experience that internationally trained dentists have today. These are skilled professionals who trained outside Canada. They want to practice dentistry. They deserve our support. The challenge we face, Canada will always need dentists. We have an aging population. We have growing communities. We have a new federal program for lower income Canadians. Access to dental care is a real issue in many areas. It can be a geographic challenge and a financial challenge or both. At the same time, we have talented professionals from around the world. They want to contribute to our healthcare system. They want to serve our communities, but they face barriers. These barriers can be unnecessary. They slow down the process. They waste talent. This is not just an Ontario problem. It is a national issue. It affects patients, it affects communities, it affects professionals themselves. What is our approach, RCDSO's approach? At RCDSO, we believe in a fair process. We believe in supporting internationally trained dentists while protecting the public. In our 2024 report to the Fairness Commissioner in Ontario, almost 50% of the practicing dentists in Ontario are internationally trained. Among new registrants from April 2024 to March of 2025, almost 60% of are internationally trained. So we are making a difference. That is good news. But there's more to do. Our goal is to ensure that there are no unnecessary barriers for those who can demonstrate they meet the Canadian standards. We are working to reduce barriers three important ways. Let me share these with you. First is multiple pathways to success. The first way is supporting multiple pathways to certification and licensure. Here is what we know. Internationally trained professionals came from many countries. They trained in different systems. They have different backgrounds. They're not all the same. So we support a common standard measured in different ways. The standard stays high. Patient safety stays our priority. But we recognize that there are different ways to meet those standards. We also allow flexibility for documentation. Some countries are experiencing challenges in producing standard documentation. We understand that this reality. For example, RCDSO accepts alternative documentation from applicants in lieu of certificate of standing where the applicant is unable to obtain one. This may occur in the face of challenging political or bureaucratic circumstances. In this case, we would accept an affidavit from the applicant that contains the relevant details about the registration history in that jurisdiction and confirms that they are in good standing in that jurisdiction, an affidavit from a candidate. Second, quality education and learning. The second way is supporting high quality educational programs and structured learning environments. Many internationally trained dentists need some additional training. This is normal. Every country has different approaches to dentistry. Technology changes, best practices evolve. Let me give you some other examples. Internationally trained dentists can currently participate in several pathways to practice. They can complete a full degree in dentistry in Canada. This works well for some who want comprehensive retraining. These are gap training programs. They are not 4-year degrees. Most of the Canadian universities offer these programs, which are some 2 years and some may have become 3-year programs. They can complete an equivalency program. This is delivered by the national examination body called the NDEB. It is a series of 3 exams. These lead to the opportunity to challenge the final certification exam, which every Canadian dental student has to take as well. RCDSO has an active memorandum of understanding with NDB. We enacted this in 2023. This ensures that service standards, capacity, and processes are meeting colleague expectations. And here is something new that we are excited about. We are actively participating in the development of a new bridge training program. This is for internationally trained dentists who are close to meeting the Canadian standards. These are dentists with strong training and practice experience. This program uses assessments and short-term training modules. It addresses specific needs of particular candidates. The whole program takes no more than 8 months. This is much faster than other options. We want to give professionals options. We want to find the pathways that work best for each person. This makes the process more fair. It makes it more effective. We're also looking at developing a pilot project. This would enable internationally trained dentists to work under approved, supervised settings in Ontario. They would gain practical experience while they challenge one of the licensure pathways. This gives them real-world experience They will interact with their colleagues and patients and learn how dentistry practices in Canada. It helps them prepare for independent practice. College of Dental Surgeons of Alberta has already started this similar pilot project. And all this information is also on PEGASUS webpage. I have personally checked the information, and it is all good information, and people can look at that as well. The third way is promoting mobility between provinces. Canada is one country, though we have different licensing requirements in different provinces. The last speaker mentioned about the having provincial licensing bodies, and I agree with that. In dentistry, we are pretty consistent across the country, and we are always looking to do better. At the national level, RCDSO chairs the multi-stakeholder working groups to review certification processes for graduates of internationally trained dental programs. This group represents all the major provincial and national dentistry organizations. It works to review current programs and to explore potential changes and additional pathways to certification and licensure. We also support provincial government solutions. One example is Ontario's as of right legislation. This means if you are licensed in one province, you can practice in another province. You don't have to start all over again. The Ontario government recently proposed expansion of the legislation to include dentistry, expediting the process for healthcare professionals registered in other provinces or territories to begin practice in Ontario makes sense. RCDSO also works actively with our provincial government and Fairness Commissioner. We want to ensure that barriers are reduced. We want internationally trained dentists to be registered quickly when they have met all the requirements. Our registration committee provides regular reports to government. These reports include data on our performance. I'm proud to say that RCDSO consistently meets and exceeds regulation requirements for licensure. We track our timelines. We measure our performance. We report our results to Fairness Commissioner and provincial government, Ministry of Health. On average, the registration department provides decision on complete applications in less than 5 business days. This is regardless of country of training. Why this matters? You know why this work is so important. First, it is about fairness. These are skilled professionals. They have invested years in their education. They have experience. They deserve a fair chance to continue. Second, it is about meeting Canada's healthcare and oral health needs. Third, it is about economic sense. When professionals can't practice, we waste their skills. We waste their potential contribution. This hurts our economy. It hurts our communities. Fourth, it is about families. Many internationally trained dentists have families. When they can't work in their profession, it affects their whole family. It affects their children's future. I want you to know that we are making real progress. At the RCDSO, we have streamlined some of our processes. We have reduced waiting times in some areas. We have created new pathways. But we know there is more work to do. We are committed to this work along with our partners. Let me close with this thought. This is not just about dentistry. This is about building a better healthcare system for all Canadians. Thank you for the work you do, and thank you for providing me with this opportunity to speak today. Thank you, and I'll be very happy to answer any questions.
Okay, thank you so much, Dr. Sandhu, for the participants online as well as those in person. If you have any question, please feel free to raise those questions at this time. We still have a few more minutes left to accommodate those questions.
All of that information is on your webpage. Actually, what I spoke about, various pathways, are listed, and I worked with Muhammad. That information is very, very complete.
Yeah, thank you.
Okay.
Thank you very much. I posted that link on the chat as well.
Thank you so much.
Dr. Sandhu there also referencing our IEHP Resource Hub. So the international health professionals in Canada, we also have an online resource hub. And there we post information about the various pathways, and we continue to update that content as well. We're grateful that he was so thorough in going through and reviewing those contents to make sure that there is accuracy in the information that is there. So you remember Dr. Santos spoke about posting all of these content, posting about these pathways, but then when things change, there's a concern of accuracy and the whole issue of going to update all of that. So we've taken that bold move to post it there with the caveat, this is the most accurate information up to this time. And so we continue to update that to make sure that we're offering value to our IEHPs that come in. And we are really appreciative of you, Dr. Sandhu, and of course, joining us today to address our participants. So at this time, thank you, Dr. Sandhu, and welcome.
Thank you.
So at this time, I'm going to take the opportunity now to speak about our next speaker who will be joining us, and that is Carol Timmings. Now, Carol Timmings, thank you so much for joining us. Carol is the Strategic Partner Liaison at the Canadian Nursing Association and a board member at the Touchstone Institute. Carol Timmings, registered nurse, Bachelor of Science in Nursing, Master of Education as well, joined the Canadian Nursing Association as Strategic Partner Liaison in January 2025. In a part-time role, she supports the Executive Office and other key portfolio in advancing the Canadian Nursing Association's strategic and operational priorities. Carol also plays a pivotal role in relationship management and the co-creation of stakeholder engagement strategy to strengthen the Nursing Association's impact across Canada's healthcare landscape. Carol is highly experienced in nursing as a leader with an extensive background in public health, health policy, nursing regulation, and governance. She is recognized for her collaborative leadership, her ability to navigate dynamic, complex health systems, both at the provincial and national level, and also some international experience or engagement as well. Throughout her career, she has been committed to health equity, diversity, and inclusion, and has consistently built high-level performing teams to deliver impactful results aligned with public health and safety priorities. And some of these are values or attributes that as an organization, and PEGASUS as an organization resonates very well with as well. Carol recently retired from the College of Nursing, Ontario, 2019 to 24, where she held multiple senior leadership roles, including Chief Quality Officer, Acting Chief Director, and Chief Executive Officer, as well as Deputy Registrar. Prior to her time at CNO, Carol dedicated 2 decades of Toronto public health, and that was from 1998 to 2018. A position in which she made significant contributions to public health nursing in Canada. Carol has also served on numerous nursing and health system boards and initiatives, including her recent tenure on the National Council of State Boards of Nursing from 2022 to 2024. She currently serves on the Touchstone Institute Board of Directors. And for those of you who may not know, Touchstone Institute is also one of those organizations that is charged, of course, with administering Practice Readiness Ontario. So they're doing quite a bit of work there across different disciplines. So nursing, dentistry as well, and medicine, to facilitate the integration of internationally educated healthcare professionals in Canada. So Carol sits on that board. And today we would like to welcome Carol to this meeting to, of course, speak about some of those strategies, some of those changes to reducing barriers for IENs across Canada. Welcome, Carol. Thank you for joining us.
Thank you so much for that introduction. And it really is a pleasure and a privilege to be able to participate in this meeting today. And I can say that the theme of the meeting really did resonate with me. In part, I think when I reflected on my own career journey and my deep commitment to equity and inclusion, I think I come to you today with kind of a breadth of experience, having spanned in the context of this work, having worked in regulation for a number of years, and also appreciating the value of partnership across sectors with both with all the players that can actually smooth the transition and embrace internationally educated, in my case, internationally educated nurses. So I like to always begin by acknowledging, on behalf of CNA, acknowledging the land upon which we're meeting, and that it continues to be the home of many diverse First Nations, Inuit, and Métis people. And this morning I happen to be joining you from north of Toronto, from the traditional and treaty territory of the Mississaugas of Scugog Island First Nation and the Williams Treaty signatories of the Mississauga and Chippewa Nations. So we honor this space. So what is the Canadian Nurses Association? Well, we are the professional voice of nursing nationally and globally. And we actually welcome and embrace all categories of nurses and nursing students, as well as retired nurses. And we are a voice coast to coast across 13 provinces and 3 territories, with a vision that includes making nursing better, but also by extension, strengthening healthcare. So our vision is on the screen there. We really want to unite nurses to advance the profession, but not to do that alone. I think that is going to be the theme of my comments today, and our dedication to a stronger workforce in Canada, in our health system, and a healthier environment and a healthy society. So we are, as you can see by the numbers, although we're waiting for some updated data from CIHR, or CIHI, but we're nearing the 500,000 mark, which is really representative of a pretty informed voice for the profession within the system. And that really is how the basis upon which we look to reflect the values of CNA, diversity, upholding excellence in the highest standards of care in this country, in embracing innovation and the new ideas and approaches that you've already heard about from previous speakers when it comes to licensing nurses. And of course, building trust not only with health professionals, including nurses, but building trust with the public as well, so that everything we do in the system is really defined by transparency and accountability. We have to be accountable for our actions, and we really do uphold that value at CNA. So let's talk a little bit about the nursing workforce in Canada. And I know by the end of today, you will have heard from a beautiful cross-representation of all the disciplines that make up our health system. But I think the common unifier is that we are living in a country that has always stood as a beacon of hope, attracting skilled professionals from around the world. And that is such a strength and such an honor for us to be able to assist in navigating these highly skilled individuals who actually choose Canada to call home. So at CNA, we really are committed, like all of you, to strengthening our workforce capacity, We see burgeoning health needs. And we also, as a previous speaker said, we embrace internationally educated nurses, but not only because, and I think there is a narrative out there that, oh, all of a sudden we need internationally educated professionals. And so now we're looking to welcome them. And that, of course, is not the case. We need to strengthen our workforce in order to really reflect the global country that Canada has become. And we acknowledge that internationally educated nurses arrive with the richness and unique blend of experience, knowledge, education, and are ready to come and apply their skills and their experience from having worked in global systems to our system here in Canada. So we need a global workforce to meet the needs of our diversely rich country. Internationally educated nurses really do bring more than their education and lived experience. They bring to our health system incredible adaptability. They bring a refreshing global outlook and an ability to navigate challenges that will enrich the fabric of our country and of our Canadian healthcare system. So beyond their clinical skills, they carry the stories of perseverance, of facing challenges, of navigating those challenges. And not only do we need to be inspired by that, but we need to listen and learn from that. So let's acknowledge, and certainly at the Canadian Nursing Association, and prior to my joining in this partnership role, I certainly heard this firsthand in my work as a regulator at the College of Nurses of Ontario, that there are challenges. We're not perfect. We're improving. We've streamlined. We've looked at efficiencies. There's a lot of great innovation happening. But I think we also need to acutely and continually listen to what are the challenges that internationally educated nurses and other professionals continue to face. And how can we come together as partners in this system? It's not a blame game. It's not the narrative that, oh, regulators are the barriers. No, we have to get past the finger pointing and look at how can we all come together as partners to support internationally educated health professionals to navigate what is a very complex system. And I think we have to acknowledge that. And we hear that at the Canadian Nursing Association. We're often the first place they come as newcomer nursing professionals or those who are in their educational journey. They often contact us and they share some of the challenges that they are experiencing. And I've noted those on the screen above. And I do note that there are tremendous improvements that have been made. I was part of making those together with my colleagues at the Nursing Regulatory Body of Ontario and worked very closely with my provincial counterparts in really looking at how we can harmonize and do more of that together, while recognizing that provinces do have specific legislation. Each province has its own nursing act. There are provincial considerations so that it can't be a one size fits all. But I do think there still is opportunity for us to do more. Next slide, please. So I do want to acknowledge that not only within the regulatory bodies, but also their respective provincial governments have done a lot, quite frankly, in modernizing legislation. The previous speaker spoke about the as of right legislation in Ontario. And this idea, and other governments have done very similar initiatives. But the idea that we all need to come together to support transparent and equitable registration processes. Some governments have offered some quite generous funding to support internationally educated nurses to complete educational requirements and are working with employers to align and welcome internationally educated nurses who meet those requirements and are ready to enter the workforce to match them with some employer needs and vacancies. Development of mentorship programs. I'm pleased to see that when I looked across the system here in Canada, and have done so for several years now, it is great and heartening to see that there are navigation assistance available, some supports for language and people meeting language requirements here, mentoring and supporting nurses as they navigate this system. Our education partners are actually offering, some of them are offering orientation courses, because it isn't enough to just meet the registration requirements. We need to ensure that new professionals to this country are oriented to the context of practice. Our system is different. It is a different system. But what can we do? And I think we need to do some soul searching here. What can we do to assist in that smooth transition to our context of care, which is different in Canada than it is in many other parts of the world? And so I just spoke the other day with employers from across the country who shared the robust peer support and mentorship programs that they're putting in place. And I think it was really heartening to see. What I will say, though, is that from a nursing association point of view, we still see that there's work to be done. And I think there's ways that we can come together and across what some would perceive as a very siloed system. We each have our unique mandates, but I think by coming together, we can solution while still respecting each other's mandates and purpose of the organizations. And I know there was reference, and there is a groundswell of voices asking, why don't we have a national licensure framework in Canada? Would it be beneficial? What are the pluses? What are the minuses? It's certainly not the panacea, but how could something like that, even in a framework, support the newly arrived professional who doesn't know when they first arrive that they need to go to a specific province in order to get licensed there? What are the opportunities to get licensed in more than one province? So I do still think that there is a gap in what is available to help newly educated international, whether they've experienced nurses in other parts of the world, or they're coming to finish their education here. There's all kinds of needs. And I do sit here today pretty convinced that there's room for further advocacy and policy action that all of us can participate in. So this slide just shows that, well, we can be the voice in the Nursing Association, 500,000 strong. It isn't just the nursing voice. I think it is the value of everyone who contributes to the system. And so I think while I appreciate that there is thinking that, well, you can't both regulate in the public interest and also support professionals in becoming part of the landscape, the healthcare landscape here. But I believe that if we work together, that professionals who are supported can actually provide the excellence and standards of care that we are all working to ensure that they're upheld in this country. So we actually encourage new professionals in nursing to come and join CNA. There's many benefits, even as a new professional, before they're even registered, to come and become part of a community of nurses. We aren't the regulators. We are an association, but we are here to support professionals so that they find where they need to go. We can help them navigate what is otherwise described by many in very rich ways as a pretty daunting experience to first arrive in a country where you've practiced potentially as a nurse for 10 years in the Philippines, and you arrive to build a life here, continue to build your life, and it's pretty daunting. And that's often the voice that we hear from. So we really want them to find a community where they can then be launched from in terms of, oh, you want to practice nursing in Nova Scotia? You need to get in touch with that regulator in nursing who will then be able to help you navigate that registration. So we really believe that it is important. And I know each respective profession has their associations. I just think there is a beautiful opportunity for us to work and collaborate more closely together in this country, both interprofessionally and across sectors within the profession. So my last slide is really, I think, a key message. I really wanted to leave today with both my colleagues and those online who may be navigating this journey in real time right now, that it is our belief that we do need you and you belong here as internationally educated professionals. And at CNA, we are advocating for you, and we need your voice, your lived experience to advocate with us, because we cannot shape and inform policy change without the lived experiences of those who have navigated successfully their journey. And while we need your nursing knowledge, your skills, your judgment in the Canadian workforce, we as importantly, perhaps more importantly, need you as a whole person with your lived experience, your cultural competence and knowledge and ways of knowing, because that's what's going to result in the kind of strong, resilient, equitable, and I would say responsive health workforce that we need in this country. So thank you for the opportunity to be here with you today. My final slide says just that. And I'm happy to take any questions, but thank you so much for your attention.
Hey, awesome. Carolyn Timmings from the Canadian Nursing Association. All right, so if you have any questions for Carol, please post those questions in the chat. And from the audience, go ahead.
So for multiple nurses that I've known and myself as well, I am a BA, was, and proceed to get my physician license here in Canada. There's a barrier called the 7 countries, which is UK, New Zealand, Nigeria, Philippines, Australia, US, right? There are multiple countries now and nationalities that they're proficient or their skills or in any kind of healthcare, either nurses, pharmacists, they have no back. Me as well, I've been encountered with many barriers in my journey just to get my license. And every time, oh, you're not from the 7 countries, then you have another different path. You have to reschool, go back to college, study for 2 or 3 years maybe. So technically you're redoing your education. So is there any chance that this might change?
Okay.
Close soon, at any time soon?
All right. So, Carol, I hope you heard that question.
I did, yes. And I can certainly give a perspective, certainly from my nursing experience. I do know that there is work underway internationally. It's called the International Nurse Regulatory Collaborative. And there has already been some research done to really look at those mobility pathways and to actually, I think sometimes we come at this as a what's different, as opposed to understanding where the similarities are, right? And I think that takes an examination. I did hear my pharmacist colleague say that, it isn't about where is that bar, right? It is about what is the level of education, competence, and in some cases experience that needs to be assessed. And I think it is incumbent upon us to work internationally to examine those mobility pathways. Where is it very comparable, or quite frankly, the same? Do we have redundancies in our processes that in fact are not necessary? So I think it is incumbent upon all of us to ask those critical questions. And I remember very vividly a meeting with the Fairness Commissioner in Ontario who asked those questions. Why are we assessing that, that education couldn't possibly be equivalent? What makes us think that the Canadian education system is so superior until we have exactly really examined what that experience or education may have been in another part of the world? So I think it's incumbent upon us to always ask those critical questions, appreciating that we all want to be clear about the mandates of each organization. And I absolutely respect and worked in regulation to know that we're focused on upholding the public health and safety of the populations that professionals serve. So I have to say I'm very heartened with the work that's underway. And is it solved? Absolutely not. But it's stories like yours and lived experiences that help us make the changes. So please keep speaking up and sharing your experience. Thank you.
Awesome. So work's on the way to look at some of those additional countries that we could add to that list, or possibly remove that list in terms of list of countries that you say are approved then to go into practice without doing this. Okay. All right. Thank you, Carol. Awesome there with that address. And thank you so much for joining us. I know you'll be rejoining later with that presentation with, or panel discussion that we will be having with the Medical Council of Canada, the RCC, and Nova Scotia College of Pharmacy. And of course, just to get that diverse picture and also integrate some of our lived experiences as well into that discussion and see how best we can work on those solutions or discuss those possible solutions that we can use to make the process better or streamline the process for those persons who are living in it. Our next speaker will be Dr. Keri McAdoo. Now, Keri will be presenting virtually. Thank you so much, Dr. McAdoo, for taking the time out to speak with us. Now, she's the CEO of Nova Scotia Physician Assessment Center of Excellence, that's PACE. Dr. Keri McAdoo has been the Deputy Registrar at the College of Physician and Surgeon for the past 8 years. In her capacity as CEO of PACE, Dr. McAdoo has been leading the development of the first, or one of the first of its kind, the PACE program, which deals with, of course, the assessment of physician there at the Physician Assessment Center in Canada. A graduate of the Dalhousie University here in Nova Scotia, Dalhousie University Medical School, Dr. McAdoo completed her family medicine residency in Alberta. So specialist, general practice completed here, specialist practice in Alberta, certified family physician, over 20 years of practice experience in family medicine in Nova Scotia. She has contributed to the development of licensing pathway for internationally trained physicians Her efforts have helped improve access to qualified healthcare professionals within this province. Under her leadership, PACE is helping integrate competent primary care physicians into the provincial healthcare system here in Canada, and in doing so, expanding primary care access for thousands of patients across Nova Scotia. All right, participants, please help me welcome Dr. Keri McAdoo, and I'm hoping that the rest of Canada, as they're listening and as she speak about challenges and those innovative practices, that we can probably extend some of that, not just have it here in Nova Scotia, but extend it to some of the other provinces across Canada as well. Thank you very much. Help me welcome Dr. McAdoo.
Thanks so much for having me. I'm very happy to speak with you today. Thank you very much for the introduction, and I'm happy to go on to the next slide. So PACE is unique. It has a hybrid mission of assessing internationally trained physicians for licensure in Nova Scotia, while at the same time providing high quality primary care. We opened our doors in February, and my aim today is just to give you an overview of why we launched PACE, how we made it happen, what's unique about this model, and where we are today. So the purpose of getting PACE stood up in the first place was to address the primary care shortage that exists in Nova Scotia, and certainly that's a well-known problem here and across the country. I'll talk a little bit about how we got it up and running, the core components of it, making it unique, a little bit about physician eligibility, the evolving practices around assessment, and then what we've learned to date. So PACE is the newest practice-ready assessment program in the country, and the pieces that are unique about it we'll go over in a little bit more detail, but it is a workplace-based assessment. So the physicians that are being assessed are overseen by experienced family physicians trained in assessment specifically. It's in a collaborative care setting, and the physicians that are doing the assessment are well trained in the tools of assessment and how to appropriately assess physicians trained internationally. It is a requirement for licensure in Nova Scotia for most family physicians to undergo a practice-ready assessment if they're trained outside of Canada. There's only 4 countries that the College of Family Physicians of Canada, so not the College of Physicians and Surgeons, but the College of Family Physicians, they recognize 4 countries, their certification, but otherwise the rest of the training needs to go through a practice-ready assessment like this. And so the challenge for many practice-ready assessment programs across the country is finding assessors to help do this work. It's important work, but it's also challenging and difficult work, and not the same as regular clinical work. And so it comes down to what we call the 3 C's for assessors. They want to feel competent, they want a community of practice, and they want to be appropriately compensated for the work. And so this model speaks to all 3 of those things. We partnered closely with the Medical Council of Canada, who have provided comprehensive, robust training for our assessors and helped us develop the assessment tools and the platform that goes into it. The PACE model is also centralized so that all of the assessments happen under one roof. And so all of the candidates are together, all of the assessors are together, and all of the patients are registered with PACE specifically. So this allows for the community of practice to develop both for the candidates as well as for the assessors. And then the assessors are also compensated for the work. The clinic doesn't see as many patients as would be seen in a regular family practice because assessment takes extra time. And so all of that is taken into account when we're looking at attracting assessors to do this work. Certainly the assessors were very keen at the program when we had them training in January, and they started the day by describing themselves as Dr. So-and-so from Truro or wherever they may be, a family physician. By the 3rd day of the training session with the Medical Council of Canada, they were saying, I'm Dr. So-and-so and I'm an assessor. So it was clear that they had really felt confident in the work that they were doing, which was key to all of this. So just to give you a brief run of the timeline of things, the Premier announced the opening of our assessment center back in October. We had originally felt that we would need a year and a half to get ready, but the announcement was that we would have the clinic available in January. So that's what we worked on doing. We hired staff, and we were given a beautifully renovated clinic facility and had 8 exam rooms. And by January, we began transforming it into a functioning medical clinic and assessment center. The Medical Council of Canada were really nimble on their feet in helping us work for this really tight deadline. And they were able to deliver this assessment training program, as I mentioned, in January. And we had our first 12 assessors undergoing that training in January, and our candidates at the same time were undergoing a new orientation and clinical observership and onboarding time in that same timeline. And that allowed us to be open for February for our first patients to be seen and for the formal assessments to take place. Our first group of candidates graduated in May and are about to enter into practice. So what the key features that make PACE different than other ones are that it is this centralized model. Typical practice-ready assessment programs have 6 weeks in one community with one assessor, or maybe 2, and then 6 weeks in another community. This, as I say, all of the assessors are in one place. So each assessor dedicates 1 or 2 days a week to this work. And so it's a pool of assessors that make up the 5 days a week, so that we always have 2 assessors in the clinic each day. It's a dedicated clinic, so it's exclusively designed for both purposes, the medical clinic aspect as well as the assessment center. So it's designed specifically for that type of work. We have rolling intakes in that when a space becomes available, then we bring another candidate in to fill it. We don't have once or twice a year intakes like a lot of the programs do. It is competency-based versus time-based. So once the demonstrated competencies have been shown in the data that we collect, then the assessment can end. And so traditional PRA programs are 12 weeks in length. Ours, we expect to be an average of 8 to 12 weeks and not more than 20 weeks. But it really depends on the individual, and it's customized in that way. They are data-driven assessments, so we're collecting a lot of information throughout the time that a physician is with us in the assessment center. And all of those little pieces of data add up to what the full picture looks like for whether a physician's ready to practice in Nova Scotia. The other piece that's unique too is that it has an immediate impact on patient care, because our patients of PACE have come off the Native Family Practice Registry, and now they consider PACE their primary care or health home place where they are registered. So they're not registered with an individual physician, it's actually with the PACE clinic itself. So the PACE program is based on these core components. It really is built on the Welcome Collaborative, which is a robust orientation program developed by the College of Physicians and Surgeons in Nova Scotia a few years ago. And we'd always contemplated that orientation program would have a longitudinal component over time. So that's one of the things that we're working on with PACE. With the Welcome Collaborative at the college, it's an in-person orientation offered quarterly. One of the things to allow us to have rolling cohorts meant that it was important that the Welcome Collaborative also be available asynchronously or at a different time online, so that candidates could access this information any time of the year, so they weren't having to wait for the quarter to come up for when the Welcome Collaborative was going to happen. So we worked closely with the college to have an online offering of this Welcome Collaborative. It is also a workplace-based assessment, like practice-ready assessments are across the country. It is seeing patients in real time. The candidates provide the bulk of patient care while they're at the clinic. And it is also a dedicated primary care clinic, as I mentioned. So it has its own medical team and its own patients that are part of the clinic. Prior to arrival, we do have online education that we offer to candidates to review before they come. Either they could be outside of the country when they're doing this online information review, or they could wait till they arrived, whatever was suitable for them. But ideally, they review this information prior to coming. And we also, as I mentioned, have the Welcome Collaborative, which, if it's virtual, can be done anywhere pre-arrival. And on the ground, once a physician is ready to undergo the assessment, they have comprehensive onboarding at the clinic, so they understand how the clinic works, introduced to the staff, understand the layout, and then have some training on the electronic medical record that we use there, which is MedAccess. So they are competency-based assessments. It is data-driven. We're closely monitoring the progression over time. And as I say, it's 8 to 12 weeks. So when we feel we've collected enough information and enough data, then the assessment will end. It could be that it's a shorter period of time, or it could be a longer period of time. The way we describe it is that each piece of data, so which is a direct observation of a patient encounter, is kind of like a pixel of an entire picture. So it just gives us a little picture of one encounter, and we add up all of those pixels to really have a full view of what the competencies are for anyone that's going through the assessment program. So the rolling intakes are possible because we do have the online orientation, we have the just-in-time onboarding, and because we can fill a spot as soon as it becomes available. We're working towards continuous application intake. We briefly opened up our applications and we're really flooded with them, so we had to close it for now until we can get through the number of applications that we have. But our goal over time is to have a continuous intake of applications. The eligibility criteria are similar to other programs in Canada. We don't require the MCCQE1 or the NAC OSCE. At the moment, we don't require TDM. That may change in time. The challenge with the TDM is really a logistical challenge. We do believe it's a good exam. It's just not offered enough to accommodate the rolling cohorts. So it may well change over time that we will require the TDM, but at the moment we don't. So the current eligibility criteria are a recognized MD and family medicine training or GP training, either 1 year leading to certification and recognition plus 2 years of independent practice, or the reverse, 1 year postgraduate training in family medicine or general practice and 2 years of independent practice. So it could the 2+1 or 1+2. If you've seen practice ready assessment programs, then that will be familiar to you. You also have to have met the English language proficiency requirements at the college, so the policy that the college has, and have to have currency of practice. And the eligibility requirement for that is 450 hours of independent unsupervised practice in the last 5 years. So when we were opening, the LMCC is the MCCQE1, so we don't require that. I see that question in there. We don't require that. It is considered a benefit to have any of the exams in the selection process. So we would add value to having successful results in that when we're looking at selection, but from an eligibility perspective, they're not required. So applicants will typically go to Launchpad, which is the recruitment firm that's helping us with this. And then we have a pre-selection process that we're helping Launchpad with. And then those that are considered to be most eligible are referred to the college. The college then ensures that the eligibility criteria are met, and then they refer eligible candidates to PACE. We then go through another selection process, and those that are chosen will go to Nova Scotia Health for interviews. You have to be legally allowed to work in Canada. So you have to either have Canadian citizenship, PR, or be able to obtain a work permit. The work permit comes, as you may know, once you have a contract from PACE, a letter of offer from the Nova Scotia Health, and the college indicating that you appear qualified for a license. I don't know when we're going to be opening applications again at the moment. So we have hundreds and hundreds at the moment to go through, but we hope to go through those in the next few weeks, and then we will decide what the next steps are after that. So I've mentioned that our assessors, we have 12 of them at the moment. They've had more than 30 hours of training. They've developed the community practice, and they are compensated to work as assessors, not just as the assessor, but as the most responsible physician as well. And the assessors are the MRP, the most responsible physician, the whole time they're in the clinic. So we have audiovisual equipment in every exam room, much like a postgraduate training program would have. There's cameras and audio so that the assessors can view the encounters from another room, which allows for better patient rapport with the candidate. We have daily direct observations, so the assessors review at least 2 or 3 of the patient encounters each day. They review what are called key tasks, which are essentially entrustable professional activities. Same thing that happens in postgraduate training programs. So they look at 1 key task per encounter that they're reviewing, and then they use an entrustment scale that's a 5-point scale from fully entrustable, no intervention from the assessor required, all the way down to unsafe or unentrustable. So this 5-point scale is used for each direct observation that happens, and candidates are provided daily feedback, and they can also provide their feedback. We do make sure that patient safety is considered number 1, so that is an important piece of the work all the time of the assessors to ensure that patient safety is maintained. And at the assessment level, we want to be sure that that's happening ahead of any assessment tools that happen. At the end of 10 to 12 weeks, we have well over 200 direct observation assessment reports, so lots of data points. It's not just 1 data point that makes the decision, it's several over time, and each candidate is reviewed by 6 to 8 assessors, so there's multiple people doing the review as well. We have key checkpoints along the way where we do extra assessments related to professionalism and communication. We monitor progress on a weekly basis with a medical consultant, and a decision is made each week whether to continue with the assessment or how much longer it would appear that there's left to the assessment, so that we can give people as much notice as we can. So these are the 14 different key tasks. They're basically things that a family physician would do in their office in a primary care setting in Nova Scotia. And this is just an example of one of the physicians that went through the program in the past. This is a representation of what the entrustment scale can look like over time. And so the blue color that you see is fully entrustable, and you can see that over time that became a larger number. And so 7% on the last slide on the right shows that they were independent, and the blue is 93%. They didn't require any supervision at all. And that's the trend that we would expect to see over time. So when a physician gets to the end, then there's a competence committee that makes a recommendation to the college. Success in the program will typically lead to a defined license, which means that you can practice independently with supervision. In the rare case, a physician might go straight on to a restricted license, which allows for independent practice without supervision. And in the occasional person, they may be recommended for a clinical assistant license. They can practice on a clinical assistant license in Nova Scotia, but they would require indefinite supervision. And then there's always the potential for a physician not to be successful, and then they would be recommended for no license at all. Next slide. So when we look ahead, we're looking at our governance structure for PACE and how that will look. We're looking at expanding our physical footprint because we need more space to allow for more assessments to happen. And when we have a bigger space and more assessors, then we can accept more candidates and we can accept more applications. And we're actively working on that now. We're looking at expanding into other disciplines. Specifically, we're looking at hospitalists in the future, and we may well have other primary care clinics while we're looking to get into the bigger space. We might have interim space in the meantime. And then as all of these programs, we will be doing a program evaluation with the Medical Council of Canada. Right now, at our current physical space, we're only able to accommodate 4 or 5 candidates at a time. And when we get into our bigger space, then we will be looking at 10 to 15 candidates at a time. And so we really are keen to get some interim space. When we do accept applications, the first point of contact is with Launchpad. So when you go on the PACE website, there will be a place to apply, but we don't have that open right now because we have too many applications that we need to review at the moment. And then when we open it again, it'll be on the PACE website. So essentially, PACE reimagines the practice-ready assessment. It supports patient care, ensures patient safety, and we certainly have required lots of collaboration with partner organizations. We're very keen on all of the data that's collected, and we're continuously improving already. I appreciate your attention and your time. You can stay tuned with our website, which is where the application will be. When we're open for applications, it'll say that again.
Okay, awesome, Dr. Keri McAdoo. Thank you so much for this awesome presentation and also showing another innovative way in which we can change the landscape and foster the integration of our IEHPs here in Canada. So pharmacy, we have you here. Here in Nova Scotia, this is a program in Nova Scotia.
We're working together.
Okay,
she's
awesome.
She's on my strategic advisory board.
Okay. Awesome. So there you go. So with not a lot that needs to be done actually to push the needle in the right direction. So you're seeing we're doing a lot of work, and as our keynote speaker says, we do a lot of these work in silos, but we need to bring these works that we're doing together, to coordinate all of these efforts. Because if it is that we start coordinating these efforts, and we'll realize that we don't have a lot left to do to get to where we need to get to. All right, so awesome there. Our next presenter, Dr. Sandra Mutilva. Help me welcome Dr. Sandra Mutilva. She's a manager of the International Midwifery Pre-Registration Bridging Program at the Toronto Metropolitan University. Now, Dr. Mutilva is a healthcare executive, academic, and midwifery leader with over 25 years of experience, spanning clinical practice, health policy, and education across Latin America and Canada. As former registered midwife and midwifery chief at the Ottawa Hospital, now the International Midwifery Pre-Registration Bridging Program Manager at Toronto Metropolitan University, she brings deep expertise in regulatory integration, culturally safe care, and systems level change. She's passionate about advancing equity-informed pathways for internationally educated midwives and leveraging innovation, including artificial intelligence, to modernize health professions, education, and care provision. So please help me welcome Dr. Sandra Mutilva as she speaks to us about what the G. Raymond Chang School at the Toronto Metropolitan University is doing to change that landscape for the integration of our internationally educated midwives in Canada. Thank you. Please help me welcome.
Thank you for the opportunity. Thank you for having me and for this opportunity to present about this new brand bridging program for international educated pre-registration bridging program at Toronto Metropolitan University. I would like to start by acknowledging that Toronto Metropolitan University is located in the Dish with One Spoon territory. The Dish with One Spoon is a treaty between the Anishinaabe, Mississaugas, and Haudenosaunee that bound them to share the territory and protect the land. Subsequent indigenous nations and peoples, Europeans and all newcomers, have been invited into this treaty in the spirit of peace, friendship, and respect. So it is an honor for me to present within this territory. So I just want to present a little bit of background related to the new this new international bridging program for midwives. So before this program, there was the International Midwifery Pre-Registration Program, where I graduated in 2004. I am Argentinian, so I got my license there. I practiced there for several years, and then when I immigrated to Canada, I was able to go through this program and obtain my license in Ontario. So that ran from 2002 to 2021, and then it stopped. And since then, there were 347 students that graduated the program, 301 practice in Ontario. 46 of these international trained midwives are practicing right now outside of Ontario. And one of the features is that 99% of the graduated from this international bridging program passed the national registration exam, which is the Canadian midwifery registration exam in the first attempt. So currently, besides the, so from 2021 and now, there was time to reimagine in a new brand program to help internationally educated midwives to find ways to obtain license. So the program has been rebranded, and and this is the first iteration, the first cohort has been just admitted. So there are other programs for international educated midwives in Canada. One is the International Educated Midwives Bridging Program, which is in British Columbia. There is one in Quebec, and this is the one for international educated midwives who are fully Francophone. And then there is another program, another bridging program in Alberta, in the College of Alberta. So this is a very, very high overview of the status of midwifery in Canada. So for people that study midwifery in Canada, midwives here in Canada are highly trained professionals and are required to complete a 4 years university degree, which is quite demanding. I teach at the ML, son of the subjects, and it is quite demanding and quite intense. So working as a midwife requires lots of time management and flexibility because midwives are on call a lot. And so it is really demanding, so it requires quite of time management, and also it's based in the continuity of care, so you need to follow your clients through a continuum. It requires of care, compassion, and ready for and collaboration, because midwives don't work in silos. So there are approximately 90 new midwives that graduated every year from the different schools. There are 6 university schools that where midwives are being graduated. plus these bridging programs for international educated midwives. So in a study that was done by the Canadian Association of Midwives, estimates that there is a need for additionally 9,000 midwives by 2030 to meet the population requirements. Midwives are in high demand. I remember that when I was practicing, we had lots of waiting list of people that wanted to have midwife and couldn't access to the care. So this is the how a high level also how midwifery is distributed in Canada. So as you can see, the provinces that the province that had the bigger amount of midwife register is Ontario, and then followed by British Columbia. So there are currently around 2,153 midwives in Canada that support around 45,391 births. So that is around 13% of the population. In Canada, midwifery is a regulated profession. Each province has its own regulatory body, province or territory. And continuity of care is one of the components. That means that midwives are going to be following their clients during their pregnancy, delivering their babies, and then providing care for the new parent for between 6 and 8 weeks, and the newborn. So there is an emphasis on informed choice. That means that midwives needs to provide lots of information to their clients and knowledge for them to be able to make the best decision for their care. It's client-centered, and there is, as I mentioned, expected that midwives are going to be functioning in interprofessional collaboration environments. Midwives here in Canada, they practice they provide care in the community, they perform home birth, birth centers birth, and also they work in hospitals. So most of the provinces, their model of work is independent. In some places, midwives are employed by a hospital, but they are not, there is not in many cases. So what is the International Midwifery Pre-Registration Bridging Program? So this is so the main difference with the anterior program that ran at Toronto Metropolitan University is that this is a pan-Canada bridging program for international educated midwives. So that means that you can't, if you are an international trained midwife, you can apply for this program in any area of the country. It is offered at the Chan School of Continuing Education. It is a blended delivery, online and in person. So that means that you can, it's hybrid. The duration is between 6 to 9 months. So you can take more than one course at a time, or you can take maybe one course at a time. So right now, the cohort that started is going to be finishing the program in April, so they will be ready to write the examination the national examination in May. So there are two times of a year that the national registration examination runs, that is in May and in October. And it is a competency-based program that is aligned with the Canadian midwifery standards. So that means that midwives are going to be assessed based on the primary care, advocate, their communications, their collaboration, their professionalism, life learning abilities, and then and their leadership abilities. So the criteria is that for being admitted into the program, they have to be permanent residents or Canadian citizen, protected person, international students with a student visa or work permit holders. Their university or school transcripts need to be assessed by a credential assessment report from an acceptable credential evaluation service here in Canada. They might have an undergraduate degree holder from a formal educational organization in midwifery or equivalent. So something that we also had, several physicians that applied for the program and they were accepted. We have several OBGYNs that applied and in the past and right now they are working as midwife and they are quite successful. So they have to practice in the role of primary midwifery within the past of 10 years, provide evidence of attended at least 100 births, and then they have to have proof of language proficiency for English. And then if you are doing your applying in Quebec, of course, is in French. So the program offers orientation to clinical placement, a skills workshop. So some midwives are coming into in some regions of the world, midwives are only practicing in hospitals and they are quite dedicated to labor and delivery, but here midwives will need to do so the scope of practice is maybe bigger because they will need to do pregnancy clinics, reproductive health clinics. They will need to work with the newborns. So we are trying to prepare the international educated midwives to perform in different settings, preparing the midwives to pass the Canadian midwifery registration exam. And then, so most of the faculty and mentorship that is available in the program, they have been international educated midwives, or they have exposures to global health. So this is how the program is being structured. So the first course, which is the midwifery skill assessment, we just ran one of them, and this is the assessment. Let's put course that they have to perform in order to be accepted into the program. That consists for 2 full days of there is training in the morning and then exams in the afternoon. There is 1 day of OSCEs. There is an interview, and then based in all that information, the candidates are being assessed to whether they are recommended to enter into the program. All the courses are online or in person in campus, except for the clinical clerkship, where midwives will need to go and work and being assessed in a clinical setting. So that is in person, and so we are working with different jurisdictions to support relocation of these international educated midwives to do their clerkships in these in different regions or territories in the country. There is also an option for extended clinical clerkship of 4 more weeks. Once they pass all these courses, they will be ready to write the national exam and then recommended for registration with a regulatory body. So we understand that there is transitioning to midwifery practice in Canada might be quite hard. Here in Canada, midwives they need to be very good communicators because of the informed choice piece of the profession, in which you have to be, you have to provide a knowledge or share knowledge with your client, so they can do the best decision for their care. It's based on health equity. Here in Canada, regulation is quite diverse. So midwives will need to be ready to practice with cultural affirmative or gender affirmative settings. And there is, of course, systemic differences from countries of origin that we are quite aware. So we are, during the program, we are trying to help to bridge those transitions. Between 2021 and October 2024, we have done lots of research in order to find which are the system level barriers for internationally educated midwives. And what we found is not different of what other speakers have presented during this forum. There are inconsistent regulatory pathway across provinces. So that is, so there is different regulatory bodies according to the province that you are going to be working. The cost for credentialing is keeping your license as a midwife in Canada is expensive. You have to pay your college fees, your association fees, and then there is also lots of, in order to maintain the license, you have to acquire constant certifications in newborn training, emergency skills. So for a newcomer who's just completed this program, it could be quite expensive. There is limited access to clinical placement. As it was mentioned here before, Canada is going through severe issue with working with a workforce that is quite exhausted. So that means that sometimes it takes a lot of work in order to find preceptors and people who are willing to be assessors. Besides, so that means that taking them out of their clinical practice. So language barriers, there is not a language training that is tailored for in the midwifery context. And then, as we meant, so this is finding the literature, that is implicit bias in assessment, clerkship, and admission process that is also, found in the literature. So there is, while the candidate is in the program, they will have access, because it's part of the Toronto Metropolitan University, they will have access to academic support, mental health, financial aid. There is an option that we presented. And then, of course, access to alumni and mentor networks. So there are partnerships and opportunities. So I'm glad that you invited me here in order to explore collaboration with other regulatory bodies, how we can support internationally educated midwives to integrate in underserved communities, and then we need to have a better national midwifery workforce data infrastructure that is not available yet. And so I'm going to lead with a call to action. So we need to, right now, this program is quite expensive, so it would be great to have funding available so we can support Sandra, international trained midwives, educated midwives to be successful in the program. It would be great to remove the silos between different regions for regulation. help for relocations, and provide support for cultural safe care among international educated health providers, and include midwifery in a federal strategy. So policy planning. So thank you, and this is my information, and so you can connect with me and be open for questions if there is time. I know that there is lots of information, but I appreciate the opportunity.
Okay, awesome. So do we have any question for Dr. Sandra Mutilva? Feel free, if you have questions, you can post them in the chat, or you can raise your hand, open the microphone, and speak to us. All right, so thank you so much, Dr. Mutilva, and you'll be joining the panel discussion in a few minutes after this that we will be having. So we'll see you back shortly. All right, thank you. There. So now we go to our institutional timer. We have with us Caroline Devar and Rebecca Martin Fraser, and we will be hearing now about the National Healthcare Language Program from our lovely partners here at ISANS. Go ahead, please.
Thank you, Dwight.
Welcome, everyone. Thanks for having us.
This is a program that we started this year, or last spring, I guess. So it's been just over a year. It's a program that we delivered in Nova Scotia first for many years. I've been teaching for many years. I've had many lovely students. And we have just gone national as of last March, so 1 year before that. So we're able to deliver our programs across the country, except for Quebec. So that's been quite exciting. And we've had students from everywhere, I think, except up north. I don't think we've had any students up north yet. Lots from Ontario, though. So it's been quite exciting. We have instructors across the country as well. We have partners. Rebecca will go over the partners that we have. And we have simulations that we've done across the country as well. So we'll talk a little bit about that as well.
Okay, so as Carolyn said, we've been offering sector-specific language courses for internationally educated professionals for many years at ISANS, and then we've recently gone national with our National Healthcare Language Program. So specifically, we've expanded 3 of our healthcare programs to the national level, which are the communication strategies for patient interactions. And this one is for pharmacists and physicians. We've expanded the professional communication skills for nurses, and also our strategies for CELBAN. So that's a specific course that's training for the CELBAN exam. So the Canadian English Language Benchmark Assessment for nurses. So these courses have been reviewed by medical professionals and are ensuring their accuracy and authenticity to meet those communication needs for the internationally educated healthcare professionals that we're serving. And so in going national, we've partnered with 4 organizations across the country to deliver the program. So our partners in Ontario are the Catholic Centre for Immigrants and the World Skills Employment Centre. In the prairies, we have Calgary Catholic Immigration Services. And in BC, we have ISS of BC's Language and Career College. So of course, ISANS is working with the IEHPs in Atlantic Canada. So between all of us, we are able to offer these courses and programs to many of the provinces minus Quebec, and therefore give the opportunity for different time zones, which has been really great for our clients because you're all very busy. And so with that being an opportunity, a lot of people are opting to take those courses at different time zones that they might not be living in. So if you're in BC and you're working and you have children and you need a course that's at a different time than what's offered in BC, you can just sign up for the Halifax course and take it at a different time. So That has provided a lot of flexibility for our participants as well. So this is our program structure, a little quick overview of our general structure. The classes are 100% online. So they're either synchronous, so they've got a couple of online meetings per week. That's specific to the course that we do with the physicians and the pharmacists, or they're asynchronous, so they don't require any online meetings, and those are all of our nursing courses at the moment. So they're between 8 and 16 weeks long, depending on which one you're taking, and always facilitated by qualified instructors. And there will be ongoing enrollment across the country at any given time. So basically, we've set it up so that it's as accessible as possible. And the cohorts for the physician and the pharmacist course are basically running every month at the moment. And the nursing courses are, you can enter one of those any Monday. So if you are eligible and you are interested, you can sign up and go through all the eligibility process and sign up and start any Monday that you like if you are in the nursing programs. So we'll look at eligibility. So in terms of eligibility status, you must be a candidate that is currently residing in Canada with permanent resident status, or you've arrived in Canada as a convention refugee. Hold a valid work permit with the MOME 23 annotation. You could be a participant in the Atlantic Immigration Program or the rural, it used to be the Rural Community Immigration Pilot. So now I think that is called the Rural and Northern Immigration Pilot. Or the Rural Community?
I think it's rural
Yes,
community.
Rural Community, my mistake. Or protected persons under the Section 95 of the IRPR. Presently, we are unable to take pre-arrival clients or citizens just due to our funding. Okay, so that's our eligibility for the program. So I'm going to pass it over to Carolyn, and she's going to tell you a little bit more in detail about the specific courses we have.
Great. Communication strategies for patient interactions. So this is our course for international medical graduates and international pharmacy graduates to help them with the OSCE. So it's one of the examinations they would like to pass and pass with high scores. We have designed the course based on the OSCE communication competencies that they need to demonstrate in the exam. And it's focused on patient communication because that's what the exam is focused on. And also it's 8 weeks long. So there's work that you need to do online. And then we have 2 synchronous classes per week, usually in the evenings, but because we have different partners, it can be at different times. And it's every month. So we have a cohort every month now. And the minimum Canadian language benchmark, that's a language assessment that the language schools in Canada use. You have to have at least 6 in all skills, so listening, speaking, reading, and writing. But I'm the program lead, and I would accept a 5 in writing because the course is not writing based, so we can have some flexibility. But we've tried with lower scores in the other skills, and the course is too difficult. There's a lot of reading and a lot of homework. At the end, we have my favorite part, which is the communication practice session with simulated patients. So I'll go over that a little bit in a bit, but that's where we practice everything we've learned in the course. So the course covers basically the interaction with a patient in the OSCEs, and the OSCEs is also simulating real life. So it works for all of that. So we start with building rapport. So in the OSCE, that's walking in the room, washing your hands, introducing yourself, and then on to conducting patient consultations, which is basically doing histories, doing it in a way that patients expect in Canada and in the OSCEs, and using the questions that get you answers faster. Understanding patients' concerns, so it's showing your ability to ask for clarifications, accept clarifications, or paraphrasing. Showing empathy, which is very important in life, but very important in the OSCEs. So the way that you're expected to show empathy, the phrases that you use, and the techniques. Offering advice, not telling them what to do. So that's a change for some of our students. They're used to being the person that just tells the patient what to do. We have to help you get the right words for gently guiding them towards doing the right thing. Ethics and patient recovery is always interesting. Ethics is always interesting, especially if we do, say, a birth control case or something for teenagers. Breaking bad news and dealing with angry patients were something that our students specifically asked for. I think it's probably the hardest part of most OSCEs because it's a lot of communication skills. For the pharmacists, we break out breaking bad news to more of a reading and summarizing skill because they don't actually have to break bad news in their OSCE, but they also have to do a lot of skimming and scanning of materials and I believe a summary of an article. So we just kind of break them out for that one class. So this is my favorite part. We started this off at Dalhousie. This is actually at Dal. So Dalhousie University helped us set up a communication practice sessions. So it was really important to have authentic exam experience, but it's only on communication skills. It's not an OSCE simulation. It's a communication simulation. So we have simulated patients trained by Dalhousie. Dalhousie helped us design the cases. We have cases for doctors and pharmacists and for Nova Scotia dentists as well, but nationally we don't take dentists. So they go through in the simulation of an OSCE. They're going room to room and they're practicing the cases, but they're doing it in pairs. So they get peer feedback, and then they also get feedback from the simulated patient, which they love. It's video recording, which is always amazing and horrifying because you have to watch yourself, but you also get feedback. You can remember everything you did or how you looked. You know, some people might not sit in an appropriate way. And then at the end, we have a debriefing session. And it also gives people an idea of what it's like if they've never done an OSCE. So that works well. Next slide. All right, I forgot to mention, we're doing this online now because it's national. So online, we're doing it with University of Toronto simulated patients and University of Calgary simulated patients. So the exact same setup, it just is online so we can reach all of our students. So the next one's for nurses, professional communication skills for nurses, our international educated nurses. And this one is for the workplace. It's not exam-based. We found some nurses were coming in quite quickly with the new language requirements and maybe getting to work and realizing they need maybe not language skills, but communication skills and the confidence in the skills that they might already have or help with some changes in some of their skills. So this is focused on speaking and listening. It's 8 weeks of asynchronous, where the doctor and pharmacist course is 8 to 10 hours per week. This one is 4 to 6 because the nurses told us they wanted a shorter course. And it's a lower CLB minimum. Very similar to the other course that I just talked about, starting the patient interaction, doing the histories, understanding what the patients are saying, you know, what slang they're using, how to figure that out, showing empathy, giving instructions and advice, educating the patients, ending patient interactions. And then we added exchanging information. So the nurses, you know, changing shifts or talking with someone else on the healthcare team or to the doctors. Strategies for CELBAN. So this is the Canadian English Language Benchmark Assessment for Nurses. It's skills-based. This course is a higher level than the last one, and it takes a little bit more time. And it has improvement strategies to help pass a language proficiency exam. We kind of compared it to the OET, and it's similar. So it's a similar approach to the exam. So this one is compatible. We've been recommending it for that as well. It's divided into 4 modules: listening, speaking, reading, and writing. You can take them simultaneously if you have a lot of time, or you can take them one at a time or 2. Listening and speaking and reading, you need CLB 7+, and writing, you need CLB 6. So these are all asynchronous. The previous one was asynchronous as well. The nurses couldn't make synchronous classes. They're all working shift work. So they can join any Monday. And then we've had the doctors and pharmacists ask if they could join these as well. Because they're healthcare based, there's an assessment at the end of all these courses. They get to practice an online assessment. They get feedback from the instructors. So a lot of the doctors and pharmacists seem to be interested in writing. I think it might be related to IELTS. So you get individual attention with an instructor and feedback on the reports.
We mentioned earlier that the nursing courses, they were blended, they were in person at one point or another, and we put them all asynchronously because they didn't have time and they couldn't meet that need for the attendance requirement. So as requested, we shifted them to all online asynchronous courses, but they were then missing that piece of practice. So they were not able to do that role play practice that they had when they had the sessions online or the in-person sessions. So we were able to incorporate AI to solve this issue. So our challenge was we're just replacing those in-class role plays and practice. And our solution was the AI avatars that we're using for role play practice now, and for the assignments that they have to submit to receive feedback. We were lucky enough to find a Canadian company called CyberPatient. So they're based out of Vancouver, and they are an innovative virtual hospital platform. Quite amazing, really. So they've got over 130 interactive patient cases. It allows them to do that theoretical knowledge in a realistic, safe environment. So they can make all the mistakes and do it over and over again and feel confident by the time they get out of there, where they can do it in real life and not worry as much. So, and go into those exams not worrying as much. So just future healthcare professionals building confidence to kind of step out into that real world practice. So this is just giving you an idea of what it looks like. I'm not going to do a demo, we don't have time, but they start out with a structured history taking. So you'll see they've got their avatar on the right side. They've got a very structured approach to the initial assessment of history taking. So they go through, you know, patient information, chief complaint, history of illness, etc. And they go through a bank of questions that they can choose from. There's about 150 questions in the bank, so they do have to prioritize because they only get to ask 30 questions. So based on that patient case, they need to decide which ones to prioritize and use to get at the end result fastest. So after immediately doing those cases, they get immediate feedback from the platform. And it kind of breaks it all down into, you know, their percentage score on their knowledge and their time spent, etc. And it also tells them, out of the questions they've asked, which ones were required, which ones were relevant, which ones were irrelevant. So it gives them an idea of how they did in terms of that. And then the actual facilitator of the course will give them feedback in addition to this based on their communication skills. The next one they would move to from that structured practice is the AI freeform communication practice. So this is where they also get 30 questions, but they're making them up on their own. So this is coming from their own skills they've learned in the course and life, and they're just wording them in their own language. And the virtual patient responds, and they get to have that interaction with them, and based on what they've been doing, but not out of the bank. It's very free form. And so they also get immediate feedback from that one as well. So it gives you the conversation. So the transcripts on the left of the conversation that actually took place, so they can actually go back and see, you know, oh, this is what I said and this is what they answered. Okay, and this is the feedback I'm receiving on how that went. So they go with positives, they go with areas of improvement, and then scrolling down or past that, it was more specific feedback to areas of improvement. So they get a lot of feedback out of it from that platform. And then again, the actual facilitator will give them specific communication feedback as well on top of that. So it's been really great. It's it's a pilot, as we say. And so far so good, but it's proving to be a good option for replacing that in-person lack of having that role play practice. So they're really enjoying it so far, and we're hoping that we can continue the partnership. So if you're interested in registering, you can go directly online and register yourself, or you can contact Olga or Lucy at the healthcare language at isans.ca. That's and they can help you if you're not sure if you're eligible or not. So they can go through it with you and then register for you. So that's our program QR code, and we really appreciate you having your conference here today. So thanks.
All right. So thank you so much. ISANS presenting their national language program for healthcare workers. And at this time, we're getting back to, we're going towards the end, but for some persons, like a really exciting part of the conversation. All right, so where you get to ask some questions as well and join in the discussion. So we have next on the agenda is a panel discussion, and for this panel discussion, we have our facilitators, of course, coming back. So Dr. Filipe Santos, MG Specialist Advisor at the Medical Council of Canada, and he is, of course, a Royal College of Physicians and Surgeons certified anesthesiologist, an assistant professor at the University of Toronto. We also have the CEO and Registrar of the Nova Scotia College of Pharmacy, Beverley Zwicker, and Carol Timmings, the Strategic Partner Liaison at the Canadian Nursing Association and board member at Touchstone Institute, Dr. Sandra Mutilva, manager of the International Midwifery Pre-Registration Bridging Program, and those are our panelists for today. And most definitely, let me say, I am pleased and honored to introduce our panel moderator for this session. Zara Abaspour, one of our own, I must say, and a powerful testament of what support, guidance, and community can do in positively shifting the scales and balancing those outcomes. Now, Zara joined the PEGASUS IEHP mentorship program at its inception in April 2024, seeking support in her journey to match into cards. All right, so that was her only statement in our intake. And from the beginning, she voiced her needs clearly. I need observership, or I need shadowing hours. And of course, we worked as much as possible to get her the resources or the support that she requested. So when it was time when she said, okay, I need hours, I said, okay, let's connect you for this. When she said, oh, I need to do OET's exam, I was like, okay, connect to this person to provide some guidance. And then when she had those lovely news, oh, I have interview. She said, I have interview with UFT. We said, okay, connect with this person, connect with this person. All right. And then she said, oh, I have a MMI interview. I don't know what this is. Okay. And we're like, okay, now we need to go and find someone from DAL who have gone through that process. And we did. So she got invited, and then she got accepted into the University of Toronto medical residency program into their family medicine stream. And we'll be starting in a few days, right?
Yes.
So now she's going to be our panel moderator, sharing her lived experience as well. And I think it's a very fitting individual to be moderating this panel. So please help me welcome all our panelists. Oh, before I go to that, now we have Lara coming back online. So let me just introduce her, please. Welcome, Lara Keeble, the Assistant Director of the Credential Policy Unit within the Settlement and Integration Policy Branch at the Immigration, Refugees and Citizenship Canada, IRCC. Lara holds a combined honors degree in Law and Human Rights from Carleton in 2002, and completed intensive summer program with the University of Utrecht, Notre Dame, and the Catholic University of Belgium, and on international human rights law in 2007. Now, currently the Assistant Director of Credential Policy, Settlement and Integration Policy Branch at IRCC. She has responsibility for educational credential assessment policy and pre-arrival information and orientation policy in the settlement program. Immigration has really been her home for almost 2 decades. So someone coming with a wealth of experience here to contribute to this conversation. Having worked across the immigration continuum on many programs across lines of business, from operations to policy and beyond. Lara has also worked in a variety of senior positions across the Government of Canada, Border Services Agency, Intelligence and National Security, Employment and Service Development Canada, with focus on disability, Civilian Review and Complaints Commission for the RCMP, Public Safety Canada Strategic Planning Policy, and Health Canada on their cannabis initiative. Now, when not working, Lara is really busy mom in a blended family of 6, and we had a little bit of discussion about that when we were, of course, having that introductory talk with regarding to her engagement in this session. I won't go into details about that, but well decorated there. So with all that professional life, you've heard that she also has a family life that you can find out as well. But please welcome, and to the rest of our panel that we spoke about earlier, welcome as well. At this time, I'd like to take myself away from this podium and allow Sarah, our panel moderator, to start off. Thank you.
Thank you. Hi, everyone. Dwight gave very nice and kind and welcoming introduction. As you mentioned, I'm Zara. The main reason that I'm here today is that to share my journeys and also to frame the obstacles and problems that some of the internationally educated healthcare professionals might face during their journey. So it is mostly from my personal experience. This is not something that everyone would have experienced or will experience, but this is just what I'm sharing here. And I'm hoping that we can find a solution for those. So one of the key barriers that I would like to highlight today is the lack of clear and transparent information about the exams and the pathway to medical licensure in Canada. So when I first arrived in Canada, I knew that the journey to practicing medicine would be challenging, but I underestimated just how fragmented and unclear it's going to be. Although there are many resources available for exam preparation, including extensive lists provided by MCC, in practice, it is extremely difficult to determine which materials are high yield and actually relevant to the exams. Like many others, I found myself relying on US-based resources to prepare for the exam, even though Canadian exams often emphasize on different competencies. I simply had no other viable choices. So as another example, recently a situational judgment test was introduced as a requirement for some family medicine residency program, FNPORC. And unfortunately, that preparation.
That's okay.
Yeah, that's okay?
Yeah.
Okay. Unfortunately, the available preparation materials are extremely limited and fall short of helping candidates feel adequately prepared. In my experience, for most of the exams, even by the time I sat for the exam, I wasn't sure whether I had prepared appropriately or not. Something I only truly realized when I encountered the questions. That said, after completing the exams, I realized that passing the exams is not the most difficult part. The real challenge lies in navigating firms, understanding what programs are truly looking for, and grasping the unspoken expectations. There are hidden rules and unwritten criteria that seems to be known only by those who are already part of the system, typically not internationally educated healthcare professionals. With no welcoming system and limited transparent information available, the process feels like navigating a complex maze while blindfolded. This uncertainty does more than delay our career. It prevents knowledgeable and talented individuals from fully using their skills. We are not just professionals seeking licensures. We are individuals whose sense of purpose and self-worth is often deeply connected to our ability to serve others through our work. When the doors to practice remain closed or opaque to IEHPs, the impact is profound. It affects individual well-being, undermines professional identity,
and place emotional and financial strain on families. On a broader scale, society also suffers, losing out on valuable skills and talent by keeping capable professionals on the sidelines. Today's panel focuses on system-based approaches to removing barriers for internationally educated healthcare professionals as they work to integrate into Canadian healthcare system. So what might be a system-level solution actually look like? So these are what came to my mind. One of them is clarity and transparency at every stage of licensure and residency process. The next one is considering the importance of ethics and behavioral science in Canadian exams. It is essential to provide accessible resources on ethical and communicational skill assessments, which are often required but poorly explained. Offering nationwide bridging, mentorship, peer navigation programs to help IEHPs to navigate the system and fill in gaps. Recency of practice requirements present a significant obstacle. These requirements should be realistic and aligned with the often lengthy time it takes to complete the licensing process. Offering research positions and healthcare-related paid opportunities that support a smoother transition into clinical roles. Nationwide acceptance of proficient-specific language assessments such as OET, which are functional language evaluation that reflect real-world communication in healthcare settings. Cross-provincial collaboration among regulatory bodies, educational institutions, and support organizations to reduce duplication and streamline integration. As we begin this conversation, I invite each of you, whether you are a regulator, educator, policymaker, or support provider, to listen with the perspective of someone walking this path for the first time. Let's move beyond individuals' stories and begin identifying the patterns, policies, and practices that can be redesigned for lasting impact. Because integration is not just about passing exams, it's about rebuilding a professional identity, restoring dignity, and creating a system where IEHPs don't just survive, but truly thrive. Thank you all. Yeah, so I'm sorry that I was reading from my notes. It was too much that I didn't want to lose anything or miss anything. So we have our panel here. You did the introduction, so do we need to? Yeah, so if there's anything that you would like to share or introduce yourself, we can go over.
I can speak a little bit to some of the things that you mentioned. I don't think we need to go over presentations again, but I do agree that there's a need on providing information more clearly to physicians. I think this has been clearly identified as a big problem. As you said, navigating the maze while blindfolded, I agree. That is a huge issue. I think one of the big contributors for that is that licensing in Canada is a provincial matter, but our assessment and certifying bodies are national. And then you have CARMS that is national, but that is just, it's national in how they process the applications, but they serve programs that are extremely individual. So it's all very complex due to that system. But I think that we have now, like at MCC at least, we identified that issue. We're trying to address it as much as we can. So the ebook was the first initiative. The second is trying to put more information on the website about immigration, about language requirements, as I said, about current skill practice and its importance for people even before they arrive in Canada to understand what they can start doing before they come here while they're still practicing back home. And as an advocate in the medical regulatory authorities to help them understand where examinations are truly needed and where they might not serve their purpose. So I think, PACE is an example where they are now, having the MCC exams are not necessary exactly because you're assessing people if they're ready to practice and not whether they're ready to enter a residency program. So I think the exams have a very important purpose at addressing or assessing who's ready for a PGY1 entry level, but they might not be needed when you're assessing experienced physicians that are going to be assessed to be in practice or not. So I think that shift in mindset of whether, like, what's the purpose of an assessment and what's the best tool to do that assessment. I think we have come to learn that, you know, workplace-based assessment, as we learned from PACE, where you're assessing competency over direct observation and 200, for example, EPAs, which is entrusted professional activities, is more adequate to assess readiness for practice as opposed to, you know, readiness for training at a PGY1 level. So I think change is happening, not as fast as we would like, but in the last 2 years, we probably saw more changes in this field than we have seen in the last like 2 decades. So I think we have reasons to be hopeful and to celebrate the recent changes while fighting for more changes.
That's true. Thank you.
I would observationally, and again, so I'm the pharmacy regulator, but I did have the privilege of, through the project that I described, being in Jordan, and it was interesting. I was at tables where there were some senior physicians, and they were really wanting me to understand that it was very clear to them the path they would take to be licensed in the United States. It was not clear to them for Canada. And they really flagged that as a significant barrier because and I think some of that is because, and not that it was even an easier pathway, I think it was just better understood because they described it to me and I thought, oh, that's not straightforward, but they could talk to it. So I just took that away for me as well in terms of, you know, when something looks like an insurmountable undertaking, not understanding what the path is a big part of that. So having that, and then having people, my other takeaway for me is going to be having people who've gone through the project to come back to both inform us, how do we communicate this better, and to be champions as well to help people know this isn't as scary as it looks and is a very doable. I also really wanted to, certainly I want to applaud, I guess, the Medical Council of Canada, because it's my understanding as I begin to get into this and look at this area of how do we create new assessment tools more appropriate for where that person is in their professional career to meet the needs of our obligations as regulators to society to make sure that person is competent, and to really embrace other tools than these high stakes examinations. And so yeah, I'm very, very impressed and looking to learn from it. And I guess that would be my other thought. There are medicine I know is doing a lot in the area of entrustable professional activities and programmatic assessment, both at the undergrad level. How do we begin to bring this research to the work of regulators in assessing in professions broadly? So I realize you've got a lot to do, and I'm not asking you to do it for all the professions, but even amongst my peers in regulation and your peers in national assessment organizations, such as the Pharmacy Examining Board of Canada, it would be great if we could share learnings and sort of stand on the shoulders of giants and be able to see further and get together. I think we would do a lot collectively better and improving the Canadian brand, if you will, of coming to Canada to be a healthcare professional, that it's understood there's a lot of similarities.
That's going to be, that would be wonderful.
That would be wonderful, I believe. I'm encouraged, like I know the system is people. We keep talking about the system. The system is people. And the people that I see now that are comprising the system, I have a lot of optimism about where we can get.
That's true. Myself, I have seen changes during the last couple of years. You're absolutely right. And I know that when people are trying, and thank you so much for saying that. So I'm trying to highlight things. So it's so good that we get this chance to connect and talk about all the things that we are experiencing. Thank you so much for all the information you shared. Is there anything from our panel, from our online panel, that they would like to share? Yeah, go ahead, please.
Hi, yes, Carol, I just wanted to, first of all, I appreciate very much you sharing your experience and perspectives with us. And it prompted two things for me. One is, and I think it's really been a common theme through all of the presentations today, and that is really listening and then moving that knowledge that we acquire from the lived experiences into policies, processes, because I do still think there is a big disconnect between what we think we know and what is actually so. So I think whether it's shaping policy, looking at regulatory processes, looking at education and bridging programs, you know, I think we have to really be authentic when we say we're going to listen and integrate where we can. And sometimes that means co-creating things, right? And I love the idea of sharing, whether it's across regulatory bodies and associations or regulatory bodies and people who are supporting navigation and preparation for language requirements, etc. I do think we each acquire some of that, but it's getting to the point where we actually share that and co-develop and co-create things. So thank you for just sharing your insights. The other point you made that really resonated for me, and that is integration. You know, we talk about readiness to practice, entry-level competencies, but what does integration into practice really mean? And I had occasion a few years ago to, it was in large academic health science centers, but to really speak with internationally educated nurses who had actually been practicing for a few years. And it was really insightful to hear from them the kinds of they're not even programs really, but the kind of environment and culture that really fostered their integration and their confidence to demonstrate their competence, right? So confidence and competence. Very, very different constructs, but very synergistic when someone has been tested at that entry-level competency. But then what is it really like to go into a practice environment and demonstrate that? What's the role of peer support and mentors and coaching and really embracing a diversity of practitioners in the workforce? So thank you for that. I think the term integration is something we need to really look at working with our employment partners who really spend more time with internationally educated graduates than any one of us, really, right? We each have our mandates, but it's when they get in the workplace that I think employers can be incredible partners in patient safety and in supporting the integration of practitioners into the workforce. Thank you.
Yeah, thank you so much. So Dr. Sandra, I can see that your hands are up.
Yes, thank you. I think that I understand and I appreciate the aspect of integration, but also there is an aspect of transparency that it will be very important to highlight that clinical care doesn't happen in a vacuum. There is a whole system around, you know, when I am a foreigner trained primary care provider, and when I arrived to Canada and after passing all my assessment, I needed to perform in a system that was quite shocking in terms of cultural fragmentation. And I think I was not quite well prepared for that. And so maybe this is something that the transparency aspect is extremely important, especially for accountability. I am also an expert witness. I have been in court hearings providing an expert opinion about clinical care. And the worst things that can happen to an international trained provider is to go through that process without the full preparation. So I think that the transparency aspect, I don't know how that could be expressed enough, that yes, you can be the best surgeon, the best nurse, the best midwife in your country, but here there is a whole aspect of a system that is extremely fragmented, that might disrupt your ability of perform to the best of your possibilities.
Oh, thank you. I can jump in.
Yes, sure. Go ahead, please.
I'm really glad that I've had my panelists go before me because I want to express some of the same themes around clarity and transparency, the human connection and co-creation, and the fragmentation of how our systems work, both as a federation and federated with provinces and territories, but also the regulator space. And I work in all of it right now. So a bit of what I see is trying to pull in all of those issues and say, what can we do better in our immigration and pre-arrival space? So I want to talk a little bit about what we do at the pre-arrival space, because we can always do more and better. And I think it will prompt a very good conversation. And I also want to just put a placeholder on employment partners. We have an important role to play with our employment partners, and within the federal family, we have that important role, and what can we do and influence? And so that's also a key topic for me. So IRCC's pre-arrival services provide eligible clients with accurate, relevant, timely information to support and make informed decisions about their new life in Canada and begin the settlement process before they arrive. Our services allow eligible clients to develop realistic expectations, make informed decisions, prepare in advance for a smooth transition to facilitate integration. Preparing to enter the labor market, make connections with professionals and employers, and access navigational supports to get their credentials recognized and set them on a path to licensure before they arrive. Access to settlement and other community supports are quick and easy when they arrive in Canada through accessing these pre-arrival supports. We try for a seamless path. Permanent resident applicants can register for pre-arrival services with their immigration application approved in principle. So it's not the earliest point in their immigration journey, but it is a point before they arrive.
I would just, while you're looking for a question, if I could just build on something she said. In our project, one of the learnings we have, because we're bringing together different partners, so we're actually working with employers, immigration, education, and then academic and the regulators. There's a lot that we assume about each other and about our processes, and we all feel a very strong sense of ownership of our part and our pathway, and we really bump into each other a lot. So I think it would be really helpful. One of the learnings that we're trying to glean from this, in addition to let's build a pathway, is how do we actually work better together? So the people who are coming, it's a different experience. It's a smoother, cleaner experience. I think collectively there's work to do beyond just the pathways, beyond just the assessment pathways, and just looking at how do we work together, whether it's aligning with what immigration requires, for instance, for education, and when they need to have their applications from a regulator and the assurances that we need to give them about how certain it is that person's going to have a license, and when employers need something from immigration and from us, it's aligning that, because we have a bit of a juggernaut, and I can't imagine how frustrating it must be for people to get caught in this cycle and trying to straighten out and smooth out some of those pathways. So I don't know if this is, I've only been in this space of working with so many partners for 3 or 4 months, and it's quite an eye opener. I don't know, you know, others maybe have been in that space in trying to pilot something with so many partners. I can't imagine actually being the person trying to come and trying to navigate each of us separately. It must be challenging.
It's very challenging because also you need to imagine you're trying to navigate all these things and nothing is standardized. So the eligibility requirements for multiple programs, from immigration to licensing to examination to financial support from the government, like all have their own eligibility criteria. So you might fulfill, you might be eligible to sit the exam, but you're not eligible for licensing. You might be eligible for financial support from the government. You might not be eligible. You might be eligible for permanent residency, or you might not. And if it doesn't align, if the Swiss cheese, if you're not lucky enough to get through the Swiss cheese, you won't get to the other side, which is ultimately living in Canada, fully integrated in your profession and actually participating in society within your profession, which is ultimately, I think, everyone's goal. But there's just so many hoops. You're correct. I think there needs to be a little bit more communication to see where things can be standardized. I see this from the medical regulatory perspective, where the provinces each have different eligibility criteria to try to achieve the same goal. So I think there needs to be more conversation between the provinces. Why can't we align on what are the requirements for certain things? And why is it that, in Nova Scotia, we don't need an exam, but if you cross the border to this other province now you do? How do we, we're the same country? I think, and although health is, provincial, I think there's a lot that can be shared in terms of experience. Our populations are different in some areas, but not overly so to the point that we need to have different criteria for every single thing, right? And that in itself would eliminate, would save costs, would eliminate redundancy, would improve efficiency. So overall, it's a win-win.
And I would just flag on that. In 2023, April 2023, the Nova Scotia government introduced the Patient Access to Care Act. And in doing that, it gave authority to the regulators to be able to waive licensing requirements when it's in the public's interest to do so. It's very unique legislation we have in Nova Scotia, which allows nimbleness, because I think some of the challenges, some of the requirements for licensure are embedded in provincial legislation and regulations that, in order to have changed, has to get in queue with things like internal trade legislation or climate. So whatever the governmental priorities are, it can be very difficult to change regulations and requirements that are regulations. So that is something that we have in Nova Scotia, and you'll notice the medical regulator here and the pharmacy regulator here are both involved in some interesting and innovative licensing pathways, and that is a big piece. So I kind of wanted to flag that as well. Just giving authority to the people who have the expertise to be nimble in making the changes.
And also making it, sorry, I was scared to just jump in, making it immune from political changes, right? Because if you have a law that gives that authority, these licensing requirements or these changes are long lasting and not based on the political interests at hand, because that can change, right? In 4 years we have another government, but if you have a law now that is harder to change. So I think that is a very innovative and interesting approach.
Yeah, I was just going to add, these are all very interesting points. I think sometimes what we see as enabling legislation actually can further the gap. I could remember I was working in regulation in Ontario when the as of right legislation came, which was seen as very enabling legislation for Ontario, but it actually had some pretty adverse implications for some of my regulatory colleagues in other parts of the country. So what does that mean? And so while I think health delivery is provincial, but I sometimes think that the way we describe innovations and having that autonomy can sometimes make the picture even more complex. So I guess I'm a proponent of looking at ways where perhaps we could harmonize things a little bit more. Why couldn't some of the registration or licensing requirements actually look the same across provinces? Why do they have to look different? When in point of fact, presumably we're all looking for the same purpose and North Star, which is public safety. So I guess You know, I've worked in a lot of spaces, and I'm yet to be convinced that there need to be so many differences. I do think that if we looked more for the similarities and less at the patchwork of, well, we don't require previous Canadian experience. Well, we do. Oh, why is that? Given that there isn't a whole lot of evidence to support either any time frame, quite frankly. So I do think I love the idea of working together, but I think we have to almost back it up a little bit to that common interest base. What are we all seeking to achieve? And then where can we make that contribution? Whether it's an educator, employer, regulator, policymakers, associate, like what is that? Because there's a multiplicity of players, but if we just keep going in our own lanes, I worry that if anything, it can get more complex, not less.
The only thing, just to make a plug, and I certainly understand the desire to harmonize, in particular, when you see a licensing pathway that looks really attractive and you'd like to have it in your own province. I will flag that as a Nova Scotian who sat on pan-Canadian boards and discussions for many, many years. I'm sure you have as well. There's a challenge in getting pan-Canadian consensus on any particular matter because we as Canadians have diverse opinions, particularly regionally. And I would say in Nova Scotia, we are not the largest province, and you're in Ontario. My experience has been that the Ontario position is the strongest position on any given matter, and or you know, or sort of in blocks. And so I just flag harmonization is great. It does come at a cost of innovation. And so I just always throw a flag of caution on the play to be working towards national anything, because it's a labor intensive, somewhat frustrating, and I don't think it gets us to where we want. But
I think Sandra has her hand up.
Yes, right now I am managing a Pan Canada program for integration of internationally educated midwives, and one of the things that I am noticing, I don't know, is that because maybe of the need of what is going on with the workforce, is that some of the barriers for licensing and registration are starting to be less. And in fact, I have been in, right now that we are doing this, I have been engaged by several provinces and territories to see, could you please see if you can send some of your students or clerks that are open to relocation, so we can help them to obtain license in the province. So I think that this crisis that right now we are going, the country is going through, it could be open opportunities to reimagining the path to licensing and to make it more, I don't want to use the word open, but to start unifying, and I like the word harmonizing. And so there is more consensus, because we are in one country. I know there are different provinces, regulation, but the need is one, and 6 million of Canadians don't have access to primary care. So this is something that we need to, this should be our common goal, how we can support that kind of a strategy. I am not seeing that at the front of, it would be great to have a national strategy to incorporate internationally educated healthcare providers, that we are lobbying politicians to see how we can support this working force that is right now not finding their purpose. I have lots of stories, but I think that, this is what came to mind right now.
Thank you so much.
Thank you all. It was wonderful to talk to you and just hear what you're thinking, just knowing that we have this conversation. This is just to my experience, getting ready for everything, doing the exams and going through the process, you feel like you're isolated. But when there is such a setting that we can sit together and talk, it makes a huge difference. Thank you so much for that.
Yeah, thank you.
All right, so thank you to our able panelists, and I apologize for the loss of our IRCC representative from the poll. At this time, I just want to ask Dr. Neil Arya just to come and do a short address, just to tell you about who we are and the organization.
Yeah.
Before we close.
So yes, I wanted to really speak to you on behalf of PEGASUS, the organizer of the IEHP program. And PEGASUS is an organization related to peace, global health, and sustainability, doing a lot of stuff overseas. And it was with the Canadian Medical Foundation asking us a few years ago to be involved in something more domestically that we got started with this program. I've run a refugee health clinic since 2008 and had an interest in newcomers. And then when it came to newcomers and professions, it seemed like a great alignment. So we're really thrilled to have this program. I wanted to thank Dwight and Azine for organizing this for us here. Dwight does an amazing job facilitating, and Azine helped a lot behind the scenes. I think that our panelists really shared a lot. That the scene has really changed since 30 years ago when I first started practice. And the whole idea of keeping people safe, supposedly, and creating barriers that persisted up until very recently, that has been as an excuse to not serve people well. I actually have a friend who was an ambassador from a South American country. He had been an ambassador in India, China, South Africa, Latin America, and a few European countries. He said Canada is really the toughest place for immigrants, even in terms of getting a driver's license and things like that. And that really surprised me because I thought of Canada as being very welcoming and open. And I think that we have to do better, and I think that we're starting to do better in this way. It's nice to see people talking about collaborating in terms of across professions and learning lessons from professions, but also thinking about the regulator, the university educator, and the professional bodies all together. And it's nice to see that dialogue happening. I think that this forum with people from different professions is actually something that doesn't take place that often. Thinking about lowering of interprovincial barriers, as people were talking about, is very important. And just like COVID, it seems like the recent threats from the south of the border may help launch some activities to reduce those barriers. So I'm hopeful about that. Where can we move forward better? I think that we still aren't looking so much at an asset-based assessment. We aren't really looking at what the advantages are, what IMGs, IPGs, IENs, what all of those add to Canadian society. And sometimes it is serving the populations that they come from, the cultural groups, the language groups, where you have that. But having the talent of managing in a few different countries is something that has to be harnessed. It's not something where you're second class. If anything, to that capacity that you have can really benefit our system. And I think that that's something we're not thinking about enough. So I would like us to be thinking further that way. I'd also like us to think further about support beyond licensure and people practicing. And so it's nice to have you coming back, those who are already in the system, giving back. But I think that there's probably a little bit more support in the first couple of years of practice that can make you even better and able to support further. And I think we haven't really designed that within the system. It's not saying that people aren't competent in their first couple of years to practice, but they could still do better and they need support in many ways. So I'd like to challenge us to look beyond. I also wanted to say another part of things for me is what Carolyn said, and I wanted to really thank ISANS for what they have done here, and Carolyn in particular. And what she had said was, well, it's not my role, but, and I would help with that. And I think I saw that intention of some of our speakers too, that I think that many of us have to think about that as we look at what we can do to make the system better for everybody. So just another thank you to Carolyn. And so that is it for me. So Dwight, let you wrap up, but thanks for a wonderful session.
Awesome. Thank you, Neil. Okay. All right. So now we're at the end of the session. All right. I want to thank all of our speakers that joined us today. So whether in person or virtually, and most importantly, our attendees. So those persons who came in person and those persons who joined us online as well. Would like to thank you for just giving us the opportunity to engage with you, you engaging with us as well in those conversations. And to our panelists as well from our panel discussion, the openness and the dedication to this important work. Now we've had a lot of conversations, a lot of talk about systems in silo, okay? And today's discussion was one of those where you see that things can actually come together. So we had 5 professions represented here today. These are all regulated professions that came together. What if we had 5 provinces coming together to support our IEHPs coming into Canada? Not just 5 professions coming together for, say, one profession. All right. So you know what I heard as well. So when Caroline talked about the National Healthcare Language Program, and then he said everywhere except Quebec. What if we can take out that exception? You understand? So that would be so awesome. All right. And so as we move forward, I just want you to think about these things. What can we do to make it more inclusive, to incorporate more of these barrier-breaking conversations, to include more of these barrier-breaking or barrier-reducing actions, implement those programs. So we have a lot of data, and our keynote speaker this morning spoke about that. We don't need to go and collect more data. We have all of these data that can inform these processes. All we need to do is to start implementing, and that is where the key part is. All right. So to ISANS, of course, led by Caroline Devar. So accessible. Oh my God, awesome. And our key IT persons as well from ISANS. Would like to thank you as well for the able way in which you led those communication with us to ensure that all of these things were set up and that we had the session as organized as possible, as best as possible as we could have gotten it. Our keynote speaker, Dr. Sepideh Behroozan, Dr. Filipe Santos from the MCC, Beverley Zwicker from the Nova Scotia College of Pharmacy, Dr. Harinder Sandhu, still online here with us from the Royal College of Dentists from Ontario, Timmings from the Canadian Nursing Association, Dr. Keri McAdoo, PACE here in Nova Scotia, and then Dr. Sandra Mutilva from the Chan School, Toronto Metropolitan University, and then Laura Kibo from the IRCC joining us. We are very grateful for their contribution to the presentations, to the session today. Now to all our contacts as well, who said yes, and engage with us. And even to the ones who said, no, I can't, but then they said, let me connect you with this person. We are indeed grateful and we appreciate the support immensely. Today's confirmation affirmed that system barriers are not immovable. They can be addressed through collaboration, transparency, and equity-driven leadership. Include the IEHPs in the conversation. Give us a seat at the table, all right? We're the ones with the lived experience, and we know what's best to respond to our needs. And that is all we're asking for. And I'd like to leave you with this one. Each one, reach one. All right? So for those persons who have gone through the process, you've gone through the system, and you have access, you're now empowered. Reach out to someone who is just coming or seeking to get into the system. Let's carry forward the connections made today, the resources shared as well, and the inspiration drawn from each other into concrete action. So the aim here is to move towards implementation. And on behalf of Pegasus Institute and its partners, so we are in partnership with the Canadian Medical Foundation, who funds our program. And again, to ISANS, thank you for attending and for being a part of this ongoing movement to ensure internationally educated healthcare professionals can thrive, can contribute meaningfully to the Canadian healthcare system. Good afternoon, everyone.
Thank you very much, everyone. We really appreciate you attending. We appreciate the panelists. We appreciate the attendees. I hope we were able to provide a smooth event to you. My name is Mohammed again, on behind the scenes. And I hope the translation was accurate enough to give you ability to understand with the accessibility that we're offering. And just to let you know, the recording of the session will be edited and uploaded to the website and the event page in the next coming days. Thank you very much, everyone, again and again.
Okay, thank you, Mohammed. That was our IT person, Data IT. Feel free to look him up, connect with him on LinkedIn or other socials as much as possible as well if you need to connect them.
Listen, we have Sepideh behind the scene as well, our project coordinator. She's just amazing in here with us.
Thank you all.
Thank you.
Thank you all for everybody for joining us here today. It was a wonderful session. Thank you, everybody.
Or IMG with the
Thank you very much.
IPG, and our IMG on the team. Zina in person, you also saw her as well, IPG, International Pharmacy graduate. So
in the middle, Dwight, so we can take a screenshot.
3 international graduates, 1 international medical graduate.
Yes.
Our president is Canadian trained, but he doesn't
so we can take a screenshot. Okay. Yeah, everyone say hi. We'll take a screenshot.
Bye, everybody. Take care.
Okay.